Yeah. Yeah. Posted with Ron. Posted to Newaz. Posted to Jaffari. I'm posting to Rari. Look like a gnarly. Yeah. We are so gnarly. We are so Harley. She ride like a Harley. Like Kawasaki. She wanna. We use on JawHacks.
Well, I can't think of a better intro than Bailey freestyling. So, Bailey, thank you for that. This is the second podcast of the day. We just shot a podcast for your channel, which, let me just pump that right now. What's that channel?
That is the Jaw Complex.
YouTube, the Jaw Complex?
Correct.
Okay. Will that be the first video posted on the Jaw Complex, the one we just shot with my wife?
It will not. We've had a few videos. We've had some discussions and some clips and one or two silly little things on there, and just trying to. We're new to it. I'm very new to social media, as these two young men know very well. Getting me out in front of the camera, sitting here was a big leap.
Are you ready to become famous?
I am not. Nor do I have any intention to.
So what's the purpose of that channel? Like, what are you trying to accomplish with that?
I think that might be a good question for Dr. J.
Yeah, I think that we have a lot of things we can offer to our patients. I think that, obviously you guys have a history before. My introduction to expansion came, basically, and I told you this before, I saw one of our patients who had gone to Dr. Evans, and I brought up to him immediately. And what I started noticing was that a lot of his patients were getting a lot of benefit, relief, TMJ, pain, airway, sleep, etc. And then what I kind of started realizing is that this procedure that we do is more than just orthodontic. You can change somebody's life. And, airway, breathing, apnea, oxygen. And so kind of like where we started noticing is that if we brought this more mainstream, rather than just being an orthodontic solution, a healthcare solution. And so I think that this is our first foray into making that more mainstream, making more from just a dental orthodontic to actually medical health. And that's kind of where the Jaw Complex is our way to kind of bring that more of a health solution to people.
And you said this procedure that we do, what are you specifically referring to?
Expansion, right? Specifically, but I mean, just the overall way we look at things. As orthodontists or dentists, we kind of look at the teeth, the jaws. And as medicine, we kind of, medical doctors are kind of focused on their specialty. And I'd say, what we're trying to focus on is that person alive? Are they breathing well? Are they sleeping well? And then kind of look at it top down, right? So what are the necessities of life? And they're kind of bringing it down to the micro level. And that could be whether it's the tooth or the jaw and things like that. But if the person's not sleeping, getting oxygen, that affects, obviously you're not alive, but it affects everything else. Mm-hmm. And then is that person sleeping? Are they eating well? Are they drinking well? Are they able to take nutrition in? Right? And then do they have infection? Is everything that the mouth and the airway is a portal to everything in the body from here to here. And so is that in a functional capacity doing this job as well as possible?
Mm-hmm. So the audience of my channel is well aware of expansion, the benefits that come with it, the need for it, basically all throughout, our society and in probably most societies across the world. We have this underdevelopment sort of epidemic where people's faces are not growing to their full potential, and that causes this oxygen problem where people their air intake is too small. I've been using the automobile analogy a lot recently, which is to say, combustion engines function similarly sort of to the human body in that, they require air, fuel, and spark. And a vehicle, if it's not getting sufficient air, immediately you see that it's sputtering out or it simply won't start. Its sensors will throw codes, right? But for some reason, in any old, average Joe knows when his car isn't functioning well. and we'll get it taken to the mechanic and get the air intake fixed if it's an intake problem. But when it comes to our own bodies, so many of us are walking around with poor oxygenation issues, and it's affecting our metabolism, and we're just functioning suboptimally in a million different ways. I've been sort of looking at expansion more and more as a biohack recently. In other words, it's not the solution, capital T, capital S. Just like any biohack, you sort of have to stack them, and they all work together to get you more optimal performance overall. But I've been trying to figure out like a way to bring this concept to the public in a way that's more palatable. And it's hard because there's no real good buzzword that captures it well. There's people use Airway a lot, hashtag Airway, but if you hashtag Airway, it like brings up American Airlines or some shit, you know? Mewing is another common one, but obviously that has like looks maxing and sort of not incel undertones, but it is what it is. Like mewing is tongue posture. It doesn't really encapsulate the whole space. But I think maybe if we look at it as a biohack, because people are into biohacks, like specifically the Joe Rogan circuit of podcasters, they're all, framing things in terms of biohacking. What do you guys think about maxillary expansion as a kind of biohack?
I think that's a fairly good characterization of what it is, because I think the biohack, kind of captures a few different things. One of them is the bio. Obviously, like we're doing something to affect a system in the body and the structure to support that system. And then we're also hacking is not essentially like natural, right? Like if we take a bunch of supplements, for example, to hack our performance, right? That's not inherently so natural, but we may do it for performance enhancement. It's kind of the same way that maybe mechanically kind of splitting the skull is not particularly the most natural thing you can do, but it is something that we nonetheless can do to improve structure and breathing and things like that. And of course, we can later get into the excellence and, pros and cons of it, but it nonetheless is a tool that we have to improve structure in a somewhat unnatural way. But so that what results from it is natural structure that we can then use to support better space for the tongue, better room to house the lower jaw, better nasal breathing, and so forth, right? I think that, and then if we think about those few things, it's just one of many tools that can be used in that space, right? So expansion isn't, and in my opinion, shouldn't be thought of so, I guess like as like a singular thing, like, hey, I or we are all about this, right? And that thing is expansion. Like
this particular brand of expansion.
No, yeah, it's, I think, very silly to really think that way. I think it's more understanding like, hey, we have an individual. This individual has some sort of, structural, anatomical, functional, maybe systemic, molecular type of problem, right? What is that problem? And then what are the appropriate hacks or solutions to offer for that person, right? And of course, expansion just happens to be one thing in a really wide sea of other things to throw in that mix.
Mm-hmm. Although we can sort of draw some distinctions when it comes to discussing what is better or worse expansion. For example, in my ebook published on Substack, I just started my chapter called Chapter 4, How Not to Expand, the Limits of Tooth-Borne Expansion. So expansion is not all created equal. There's dental expansion. Then there's, you could say, a second category of expansion, which is skeletal expansion, bone-anchored expansion. And then within skeletal expansion, of course, you have more distinctions that need to be drawn, which is particularly what I want to talk to you guys about today, because you are offering, I want to call it the latest and greatest, certainly the most hyped as potentially becoming the latest and greatest skeletal expander that exists, which is the FME, the Facegenics Maxillary Expander. Can you I guess before we dive into what separates the FME from, let's say, an MSE type 2 or a partner's custom MARPE or a TPD that comes along with Casey Lee's ease, that's really the crux of what I want to talk to you about today, is technically what makes the FME different. But can you just speak to how skeletal expansion in general, splitting the suture, has changed our ability to make the box bigger, so to speak?
I think by definition, it's of course broadened that scope quite a bit, right? I think cases that used to be the only way that you could navigate a solution around that case and treat it comprehensively was to have a surgical orthodontic treatment plan, right? For those viewers who are wondering what I mean by that, when you can move teeth with teeth moving appliances like braces or Invisalign, then you can basically, move them into a bite, or you can just move them within themselves to be straight for then a surgeon to then align, however which way is suitable for that patient's face, bite, airway, whatever, right? And so, surgical orthodontic treatment plans, once upon a time were the only way to overcome perhaps larger discrepancies or problems, not otherwise fixable or camouflageable with traditional orthodontic.
When you say a surgical orthodontic plan, does that mean just prepping a patient for an orthognathic surgery?
Yes, that's at least what I mean for it to be in this context. Yeah.
Okay, you're not talking SARPE?
No.
Okay.
Even though SARPE, I guess, fits in the cocktail of surgically facilitated procedures to overcome certain problems. So, of course, before the advent of bone-anchored expansion, then you did have SARPE as one of the, tools in a toolbox of trying to correct different malocclusions, right? And of course, your classic, transverse deficiency was, one of those things where, then you have to make a decision. Am I going to do a 2-piece Lefort? Am I going to do a 3-piece Lefort? Or am I going to do a SARPE? Right. And those were pretty much your cocktail of options if you had transverse maxillary deficiency in the past. Now you could have transverse. Oh, go ahead.
Just briefly, you seem to be speaking in terms of malocclusion, but are you also talking in terms of airway correction, or are you just talking traditionally this is how orthodontists and surgeons have approached expansion, was purely from the perspective of occlusion?
Generally speaking, it was. And that's why my answer is sort of sounding a little bit more like that. Now, we may be happening to correct an occlusion problem when we are also primarily treating an airway problem, right? And so even if it's taking the same occlusion and just simply moving it forward in the face, right? It's still correcting an occlusion. It's still, so it's... so by saying the word occlusion, and this is another thing for the viewers and especially your viewers, is that when you hear certain buzzwords, don't think that there's like ignorance or, that two things can't be true at the same time, right? What's that thing called? Schrodinger's cat?
Yes.
Have, maybe we were talking about and focusing on one thing and maybe something that seems to be contradictory to it. It's not that thing also can't be true, right? So conversationally, and a lot of us, right, like especially now that I'm like for the first time in my life kind of in a little bit of a public space, I'm going to say one or two things, and then people are going to go on the talk space and say, oh my gosh, Newaz said this.
Newaz doesn't care about airway.
Yeah, exactly, right? Because they'll hear one little clip of me talking about malocclusion, not understanding that inside the computer that, is all of our brains, really, that all of these things can be true at one time. So that's just, this is also a message to your viewership not to really do that to anybody, not just me, but really to anybody, because then those are the very things we have to waste our time answering when patients come to us for consultation. Right. And that's, again, it's a fair thing. I mean, we tend to be the office or the doctors to go to handle those types of inquiries. But this is just so, critically think, people. You know what I mean? Like, understand that, you know, it's possible that, you know, we could be talking about a lot of things, and that, you know, perhaps there are situations that might call for a little bit of, you know, deviation from what we usually say or usually do to treat that individual circumstance correctly.
Sure.
I just went off on that tangent because I think your question was, I think, positively triggering, because it actually got me to think about, you know, again, you know, we're thinking about ways to make our communication with our patients more efficient and effective. And this is one of those things that we actually confront every day in practice, is that, like, you know, we have certain, I think there are certain buzzwords that kind of float around the echo chambers of this space, you know, right? Whether it's JawHacks or Facebook or, you know, Mewing or Discord or whatever, right? You know, there's just a lot of things, I think, that there's certain assumptions that are made when talking about and deconstructing these issues. And really, our whole purpose of existing is to help patients, defragment some of that information, make it make sense.
Not to go too far down the rabbit hole of occlusion versus airway, but it's one thing I've been doing a lot more of recently is trying to distinguish between different types of orthodontic surgeons in helping patients choose what is the right, which surgeon should they talk to and consider. And one of the differences I'm finding is that, so I think, and please correct me if I'm wrong, but historically, orthodontic surgeons and orthodontists don't treat airway at all. They treat occlusion primarily. So in your training, you probably didn't hear much about airway. You heard about correcting bad bites, moving the jaws into a certain configuration such that the bite is now appropriate according to some standard.
Correct.
Okay. And presumably that standard is well understood. How the teeth should be in relation to each other can be perfect while the airway still be small.
Absolutely.
You could pull the perfect bite backward or pull it forward, as you mentioned. But so to my point, though, I'm finding that some of the more popular surgeons, and I'm not going to mention any names, but they still seem to be more occlusion focused and less airway focused. And so less believing in the idea that making the jaws, moving them forward and making the whole thing bigger has any impact on airway, and less willing to treat toward that end just because that's not what they do technically. So that's the only reason I bring attention to the airway versus occlusion distinction, because still I think most providers out there really are only thinking about occlusion.
I think that you know, there's a lot of research that came out. I think University of Alabama did a lot of research on advancement of the mandible and MMA surgery on how it affects sleep apnea, and it's very evident that doing double jaw surgery can literally solve for most patients sleep apnea and airway issues. And so I think that kind of what you're saying is that classically trained, you know, a lot of it is probably occlusion based, but I think it should start transitioning into that we can actually do surgical interventions to correct breathing issues.
No doubt.
And I think that, you know, going back to, you know, the medical realm, it's easy to give a Band-Aid treatment, whether it's a CPAP or mandibular advancement device, and not actually look at where that obstruction or where that problem lies from the beginning of their nose all the way down to their, you know, airway, right? And so if you could figure out where that obstruction is, whether it's in the nose or the hypopharynx, wherever that is, if you can figure that out, you could potentially solve it permanently, right? And that's where this conversation can be had as well too.
And I think it's all about establishing some hierarchy to the paradigm, right? All of these things are important, right? Teeth, bite, face, airway, all of them are important, but what's first, right? And, you know, I think many of us in this space contend that airway is first, right? And then, of course, while you're doing airway, you know, of course, respect the face. And then when you've figured out the face and airway equation, then where can your puzzle pieces then fit to, you know, reasonably to match that goal, right? And the way that, you know, here's the way that, so there's a prominent periodontist, Dr. George Mandelaris, you know, when we worked together on patients, right? he'll, I like some of the language that he uses in saying like, hey, like if that's where a patient's teeth need to be for their airway to function optimally, then put them there, and we can do whatever supportive procedures are necessary to put them there, right? That really captures this illustration of this paradigm that I'm talking about, right? That airway first, and then obviously for that thing to be true, then, maybe the teeth or the jaws or the bones need to be somewhere. And then now how do we get them from where they are to where that place is? And there may be a cocktail of different treatments, to get them there. That's kind of, thinking like that is really, in a way, a nutshell of this whole space, right?
For sure.
Yeah.
And we've discussed how skeletal expanders can be part of that equation in terms of airway construction, and also, having a major impact on occlusion as well, being able to widen the maxilla to fix, would it be called a bilateral crossbite when the maxilla is just too narrow as compared to the mandible? You can fix a crossbite at the level of the bone. That would be the occlusion perspective. So not to, don't want to go too far down that rabbit hole, but I want to start talking about FME now, basically, is what I'm saying. Tell me about your history in the different expanders you've used and how you've arrived at the FME, and just try to make it sort of a historical perspective on maxillary skeletal expanders.
Yeah, that's great. And actually, just to kind of touch on something that you were saying too, I think it's important also for the viewers to know that, yeah, you could have a bilateral cross, even just if we're just speaking in terms of occlusion, you can have a bilateral crossbite that requires expansion. You can have a unilateral crossbite requiring expansion. You can have no crossbite that requires expansion if both jaws are narrow, right? And then, of course, if the maxilla is narrow, you could either have a lower jaw that fits within it, fits on one side of it, or fits on both sides of it. That's basically, that you can have all three types of crossbites or lack thereof and require some sort of skeletal expansion or have a transverse deficiency of the maxilla. And so really that's actually a decent segue into kind of what comes next is as far as like my sort of historical relationship with expansion in general. A lot of this comes from, and then I'll get specifically into the bone anchor part of it, but just like a brief, sort of 2-minute history on sort of where, this all started for me. I had orthodontics as a teenager. I had, 4 premolars extracted, and so forth, and things were brought in, pulled back and whatnot. And, by orthodontic treatment standards, my treatment was done quite well. And, I've not really gotten complaints about, sort of my, your teeth look good kind of thing. I mean, that's, again, the orthodontist did a very good job. And then I kind of, grew to then, of course, study dentistry and then go into radiology first and then orthodontics, right? And so when I was training as a radiology resident and then later practicing radiology, of course, we're trained to look at the airway, we're trained to look at the facial bones, we're trained to look at the interplay of all those structures. I think that was probably one of my core foundational influences. That then when I became an orthodontic resident, I'm taking this background of reviewing, medical and dental imaging to study airways, study noses, study jaw joints, and think about the connections that may exist therein, and take that into, sort of my clinical training as an orthodontist. And then when you start seeing, and then you start getting some real world practical experience and seeing like, okay, this is how my non-extraction cases are coming out. This is how the extraction cases are coming out. These are where the patients are more comfortable. These are where the patients are less comfortable during treatment. Those kinds of reflections, kind of started to all sort of connect when I was in training as an orthodontic resident. And I was very fortunate. Again, I'll say this on, pretty much every time I talk about this, I was very fortunate to have a program director and a leader in my education who was supportive of me kind of thinking a little bit outside the orthodontic box. And so, and I was the only one out of 8 residents and 6 faculty members who themselves had premolars extracted. And that's why I did my residency thesis on that subject, is like, hey, do orthodontists who've themselves had their premolars extracted, do they think differently about, are their attitudes about premolar extractions different than those who haven't had?
I had mine out, and it definitely influenced the way I think about this stuff.
Absolutely. Right. So I think that, altogether, that's kind of where I became, a little bit of a more expansion focused provider. We're now thinking of ways to make the box bigger, not smaller, because you're thinking about airway, because you're thinking about trapping the jaw joints, because you're thinking about, the aesthetics, right? And just seeing that, just the extraction cases just didn't look as good, right? Or whatever. So, so then I go, I graduated orthodontic residency, and then I kind of went on a tear of sorts for continuing education. And I kind of consumed as much of the cocktail as I could. Meaning I took Juan Moon's MSc course. I went to, Clifton, New Jersey, took Barry Raphael and Mark Cruz's Airway mini residency. And then I took a MyoBrace course, and I took a this and that. I went to go see Bill Hang in Vegas. I did like a lot of these things. And, of course, I'm seeing the same people at all the same meetings, at all these different meetings around the country, because it was at the time, kind of a small group of people who were just kind of sort of following this little track. And obviously things have blown up quite a bit since then. That was like 6 years ago, right? And then, and so I take, of course, that sort of cocktail of training and stuff, and then I start implementing it in practice, right? Just, to the degree I learn something, and then I'm kind of trying new tools. I have the same philosophy of treatment. I know I kind of want to go this way and that way, right? I want to go outwards and forwards, but, I'm just trying to basically pick up more tools to do it, right? And of course, I think perhaps the most influential of the things that I learned about was bone anchored expansion, and A, that it was possible, B, that it was, biologically, I think, defied what we were taught in residency, and it actually works, right? There's actually evidence and papers and this and that to suggest that this is an actual physical thing that can happen.
We can also see it on the CBCT.
You can also see it on the CBCT. So, and picture don't lie, right?
The diastema doesn't lie.
The diastema doesn't lie. And that, even that may be a somewhat, dissectable topic, but we'll save that one because there's something that some people think are fake diastemas because of hybrid expansion pushing the teeth and the bone, and you don't know where but anyways, sure. But that actually is going to become an important point of, now talking about different kinds of expansion.
And some people might have a big skeletal expansion and get no diastema or a little diastema if it's more posterior potentially.
I think that's, at least the diastema maybe becomes a little bit less conspicuous if it's more posterior, or it's just that the methods now used for quote unquote posterior expansion, right? Classically FME and E's or whatever, will be done so slowly that it's really just simply a matter of the interseptal fibers in the teeth, right? There's currently no type of expansion that exclusively expands the posterior, right? And so if you have posterior expansion, that unzips its way to the front and you get a successful full split of the mid-palatal suture, you will get anterior and posterior expansion. I think the question lies into what proportion, right? Is it 1-to-1? Is it, just all anterior and no split at the posterior nasal spine? And I think that's where some of the, divergence between different kinds of expansion patterns is talked about. And then what is actually true and what we've actually observed is that you can have the device matters so much less than people think it matters to achieve those patterns. It's more about how the expansion is planned and carried out, and where, the doctor decides to put the anchorage, and also how that individual's bone in the whole physical equation, right? You have a subject bone mass, right? And then you have some kind of center of resistance in that bone mass. And then you have a force application. You can either apply that force with vertical screws, or you can apply it with a, lateral bar. It doesn't really matter how you do it, but the physics of those two things are different, So to also talk about those things like apples and apples is also wrong. But, but let's say that you have all these, things at play, then that is what influences the pattern of expansion, right? So you have to know that the device you're using, applied the way it's applied on the particular subject bone mass that you're applying it to, will result in XYZ pattern of expansion. That's really the way to think about it. And that's, I think, so as excited as we are to talk about and let the world know about, what we think are some great things about the FME, this remains my ethos with expansion even today, right? That, you can get parallel or anterior expansion with, or posterior expansion with any kind of expansion medium. And sure, there are certain factors that may promote expansion pattern to be this shape or that shape or whatnot. And I think we're seeing that. I think we as a expansion community are starting to be more critical and scrutinizing that issue more. And then as far as the actual clinical significance and universal application of these, of course, let's say that one type of expander or expansion pattern, right, is a little more anterior, right, or results in a little more anterior expansion pattern. Then is that clinically significant from a full posterior expansion? I think oftentimes it can be, because if you're not getting sufficient posterior expansion for somebody whose problem is posterior, then obviously that's not going to be really addressing the primary problem. But a lot of people may have their primary problem being more in front.
Can it be said universally that nasal breathing problems are always posterior?
No, absolutely not.
So this generalization that the more posterior the expansion, the better the nasal breathing result is incorrect?
I think it's incomplete at best. And I think it's incorrect to, say that in an absolute sense. It may be generally correct that you are going to get a more excellent nasal result if you also get posterior expansion, right? I think that's safe to say. But to say that, that posterior expansion is categorically better than anterior expansion, and to separate them and to, think about device patterns doing this or that, is somewhat of a, futile debate, really, in my opinion. Because even those of us who are obsessed with posterior expansion, right, what's one of the anatomical structures we talk about? We talk about the nasal aperture, right? And we talk about the nasal aperture's width as
which is to say the front of the nose.
Well, it happens to be the front of the nose, right? It is literally the measurement of the opening of the nose anteriorly as you enter the skull, right? And so
sort of just above the anterior nasal spine?
Generally, yes. Yep. And it's kind of like an oblique structure, so it may be situated, either right above or, a little bit forward or backward of anterior nasal spine. And so we're talking about posterior expansion being God's gift to mankind when we're using an anterior structure to define it, right? So I think that that's where people need to start, kind of being a bit more diverse with their thought patterns about, anterior and posterior expansion. Of course, for those who are educated about expansion, that is. But, our primary role as clinicians is, our patients are coming to us with a problem, right? We have a solution for the problem. And in most people who aren't necessarily seeking a theoretical, sort of advancement or benefit with a particular type of, is that?
Well,
I was asking if you want me to close the door.
No, it's all right. Yeah. Close if you want, close the door. We hear the baby crying. The baby's home, and we can hear her.
Bringing some life to the house.
Yeah, definitely bringing some life, but we're 2 floors up, and she's definitely landing in my headphones. So, but continue.
Yeah. So basically, I think that I think that anterior and posterior expansion can both be important, right? So us as clinicians, right, we can see. I usually like to, in my imaging analysis, walk the patient through, the front of their nose all the way to the back part of the airway, right? And so we
using a CBCT,
right? And so you can scroll through a stack of coronal or frontally facing slices of the CBCT, and you can start to appreciate the nasal tip, the nostrils, the nasal valves. Then you pick up the nasal aperture. You start to get into the bone-bearing part of the nose, and you can see the septal, configuration and thickening and deviation and whatever. You can see turbinates. You can see adjacent air spaces. You can see the sinuses. You can see the osteomeatal complexes, which is basically a little conduit between the sinuses and the superior part of the nose. And then you're walking back, and then you get into the pharyngeal airway. And so you look at all those things critically because, you can see that people have different levels of resistance in different parts of the nose. Sometimes it's before you even get to the bone-bearing part of the nose, in the soft tissue of the front of the nose, right? And sometimes that's somebody's bottleneck. Sometimes that's their biggest bottleneck, right? And so thinking about those things, and then also thinking about, different skeletal, deficiencies that people have. Some people have vertical maxillary excess. Some people have vertical maxillary deficiency. Some people have, a deficiency of anterior projection of the maxilla, right? And so when you're kind of thinking about, like, if you think of like a really, really short maxilla that's also narrow and pulled back, right? And then you're thinking about, okay, now you've got more of like a bulldog bite kind of pattern, right? Wouldn't we think that it would be beneficial to bring this person's maxilla down and forward, right? So it's like, if you think about, and then of course, and maybe the teeth are so jumbled up that, to simply create space for the teeth and create more room for the tongue and perhaps to deflect the maxilla, anterior part of the maxilla down and forward, may be of some benefit to treating that particular patient, right? And then somebody with a vertical maxillary excess pattern with a really deficient mandible, well, then maybe now we want to think about, letting the patient know that, hey, you're going to need surgery after we do this skeletal expansion, if we happen to do skeletal expansion. But, this is what the expected result of the expansion is going to be, and perhaps may make, the gumminess more prominent. And so we just have to understand the effects of our treatment. And of course, as we get deeper and deeper into understanding different kinds of expanders and where to put the anchorage and this and that, and the actual skeletal expansion patterns that we see from those choices that we make, then that helps us make better decisions. I mean, with respect to, and I think this is an evolving science. I think, this is something that, you have to do a lot of these to know what, some of these variables even are. And you have to do enough of these to, with a somewhat questioning mind, to understand what is actually the effect of our expansion. Because somebody who's simply seeking nasal breathing gains from expansion, almost everybody will get some variety of that. If you've successfully expanded the maxilla, you will probably get, at least in 98% of patients who seek expansion, some sort of measurable, objective or subjective report, like, hey, I can breathe better through my nose. And many non-expansion seeking patients are happy with that and don't need a lot of expansion, and you put the bite together and so forth, right? And so it's like, when we do the same thing for individuals who really kind of think a lot about these things, then it brings up a lot of this discussion. I think it's very healthy discussion. I think it's discussion that really has made me actually, question, like, of course, here I am sitting talking about, like, hey, well, better nasal breathing, we're giving you better nasal breathing, what else matters? But a lot of else matters, right? Thinking about how the pattern of the skeletal expansion is unfolding, and also the risks associated therein. I think these are very, I think these are very important topics to think about and talk about.
Mm-hmm. Mm-hmm. Yeah, I mean, that's a lot to unpack there. You're sort of bringing a whole different perspective to the space, rather than thinking in terms of these sort of dualities of anterior, posterior. There's obviously more to it. Can you talk about the tough lessons that you've learned using these sorts of expanders over the past 5 or 6 years, and how the technologies have evolved to keep up with the challenges that providers have faced, and where we're at now with the state of the market? terms of technologies available and limits of those technologies, and maybe incorporate FME into that sort of conversation?
Yeah, definitely. Because I think FME is perhaps a direct response to a lot of those challenges or shortcomings I'm about to mention, right? I think a big part of it initially, right, was just there are variables in seating a bone anchored expander. If you're using traditional, bands and other things, and you're pushing this thing on and off the teeth and trying to get the thing aligned, and then you gotta, check, to stand behind the patient and kind of, and stand in front of the patient and check, and then, you have to rotate or reposition your appliance to make sure it's not kind of cockeyed in the mouth, right? And then even understanding that that's important, where with tooth-borne expansion, you just got to push the teeth out sort of as, they're basically just, going along for the ride in the expansion. You get a little skeletal, and then, you put the teeth wherever you want to put the teeth. It becomes, when you have now a rigid bone anchored expander, it becomes more sensitive to, basically inequalities in all three dimensions of space, right? Roll, pitch, yaw, all of that, right? And so now we've started to kind of learn that, now expansion can be tilted. Now maybe I don't want to put this expander conforming exactly to the patient's anatomy, because the patient's anatomy itself may be slanted. Maybe I don't want to try to overcorrect for that thing, because maybe that means another structure affected by the expansion could go the wrong way, even if something's going the right way. And what I'm talking about in particular, let's say somebody has, a slant or something, right? Or a cant, and, maybe the left side's higher than the right, let's just say. But let's say the left orbit is lower than the right, and then now you're thinking, okay, well, I can expand and the structures are going to behave one way. If I try to correct for the occlusal plane problem, am I going to make the orbital problem worse? It's just basically that, we have to think about all these things when we're doing expansion. So I've learned to basically have to think about all these things, and whether the planning of the expansion is going to indeed predictably, do what we want it to do. And then how do we do it in such a way where, we can maybe intercept things if it's not doing what we want it to do? And what are some ways to correct or adjust for that, right? So I think learning all of that, obviously it's led me to, so now just kind of making this simple bullet points, it's led me to go super slow with the expansion. It's led me to be a little bit closer with monitoring with expansion. And it's led me to understand that probably expansion's number one problem as it exists today is symmetry problems, right? And symmetry problems is a result of Newtonian physics, where one side must push off of the other side in a structure where you may have differential amounts of bone resistance in the face, right? When you do that, then if, generally early on in expansion, these things are not really much of an issue at all, right? The tension required to split the palate will eventually be overcome, palate will split, and then expansion will propagate. And then perhaps at a certain point, of course, suture disarticulation happens progressively, right? So you'll have mid-palatal suture disarticulate first, right? And then you may have other sutures start to kind of give out. Well, if some of the sutures on one side are giving out a lot sooner or a lot easier than the other side, well, there's your differential bone resistance.
Right. What are some of those sutures?
Yeah, so some of the sutures are the pterygomaxillary suture, that's in the back, right, connecting the maxilla basically to the skull base. Then you have your zygomatico-frontal sutures, you have your zygomatico-temporal sutures, you have your frontonasal suture, right? So you have a lot of these different, so you have a lot of these different sutures that, let's say zygomatico-temporal, as described by Dr. Juan Moon, who's studied a lot of these things, is perhaps the fulcrum point or the rotation point about which expansion occurs in skeletal expansion, right? And so, so we may see cases where, let's say, particularly that, which, let's say if it's the pinnacle point or suture of, involved in expansion, and it disarticulates early, and much more than the other side, well, then that's one reason why you might have one cheekbone start flying out a lot more than the other, right? And then you might see frontonasal, right? You might see that's why one side drops more than the other, right? You just have all these different sutures that maybe have different significances in terms of what we've kind of seen to be complications with expansion.
And how much of these asymmetries that happen with skeletal expanders are a result of asymmetric placement of the appliance? Maybe that was something that happened more early on in the early years of these expanders, 18, 19, 20, let's say, versus how much of it is just biological variations and asymmetries that pre-exist?
Yeah, I think it's a little bit of both. So I think, like, for example, your case, right? Like your case, expander went in, straight, but, again, you kind of put certain forces on the skull, and then the expander starts to behave a certain way, right? So the resistance and the, rotational control within the expander mechanism itself is important. Your case taught me that, right? Your case also was a big lesson to me on speed of expansion, right? Like you were kind of the first case that really kind of, like with really, really aggressive turning for a while, right? And then, we see, yay, the suture splits, and now we want to carry it. We want to try to get the biggest maxilla that we can, right? That was kind of like, and so, and I want to be candid about this talking to your viewers because, we all know that, I did your expansion, and, that expansion happened several years ago, and you've been on a quest to kind of correct your occlusion and other things since then. And so, I think that in those earlier years, expander placement was an issue. Also understanding the effect of expander dimensional stability as you activate it, right? You remember one thing that happened to your expander, it started looking pretty ugly at a certain point where like one bar was here and another thing was there, and it looked like it was coming apart.
It looked like it went to war.
It looked like you went to war, right? And you turn it 26 times in 3 days. That's gonna be a little bit of a start of a war, right? And so it's like, so some of these things happen, and then that promotes the expander to drift, or it expands the, it promotes some things to drag or be more susceptible to those things, right? And so I can't necessarily say that I really firmly understood that, right? At the time that, because we were following Juan Moon's guidance, right? Early on, right? 4 to 6 turns a day, whatever. Then we all learned, those of us who were doing a lot of these, learned individually in our own ways and through each other that is not at all the way you want to do skeletal expansion, right? Because it's ultra aggressive. It promotes all kinds of risk and failure and this and that, right? Then now let's evolve to the, era of CBCT guided, expansion planning, right?
Specifically, TAD placement?
TAD placement.
Tell us what that means.
Yeah. So, of course you have, so you can have a prefabricated expander body like the classic MSE, and you can actually even plan that, right? Like you can have the lab have a digital object of that and superimpose it on the impression and superimpose that impression on the CBCT. And then you can plan how long the screws need to be and where might be a good position to place that particular object, because you have that object in your digital library for purposes of planning and diagnosis.
Could you take that MSE, the actual MSE type 2, I think it was type 2, right?
Mm-hmm.
And actually adjust whether it was going to be flush to the bone or flush to the bite plane? Like, could you do all sorts of different customizations with it like that?
Well, I think, so inherently no, because, all your screw holes and everything will move as you tilt it. But you could still, like, let's say I want this MSE here in space, and that results because of asymmetric undulation in the palate, the need to weld things to the underside of the MSE or otherwise, to make it flush so that you don't have an air gap when your screw goes through the hole. Then those are the types of adjustments we would have to make. Or that if it did need to tilt, well, now you have to think, well, my screws are going to tilt with it, right? And is that appropriate for the situation? Well, at least having CBCT helped us better understand, because if you can see the orbits, you can see the cheekbones, you can see the nose, you can see the nasal floor, undulation, and you can see the palate undulation, and you can see the occlusal plane. You can see all those things and make a decision how you want to tilt your expander, right? Or not tilt it, right? And then if you're making it flush with the palate or flush with the occlusal plane, what does that mean for the skeleton? And what does that mean for where you may already have too much prominence on one side of the face versus the other, right? So the advent of uncoupling, because see, the expander screw is embedded in the MSC device, right? In the MSC type 2. So the MSC type 2's TAD holes are going to, tilt or rotate in direct response to where you place it, right? Versus with a custom MARPE kind of workflow, you can uncouple the orientation, twisting, tilting, whatever, of the expansion screw component from where the TADs go, right? You can put the TADs wherever the heck you want in the palate. You can design the underbody of this custom hardware however you want. You can place them paramedian, you can place them alveolar, it doesn't matter. But you are the boss, right? You pick where that anchorage goes and how much of it you want and how to angle it. You're not predetermined to strictly parallel. You can maybe do a little better than parallel. And I'm talking about the paramedian TADs. And what I mean by paramedian is, of course, the TADs that are on either side of the mid-palatal suture, not even those side TADs or alveolar TADs. I'm just talking about the central TADs. This is an example I've given to a lot of patients that, the palate bone, right, is like a little bone sandwich, right? You have the oral side, you have the nasal side, and you have a thickness of spongy bone in between, right? And so you engage that in parallel. Well, you're engaging actually the minimal possible surface area that you can engage. Then maybe you get, of course, one of the problems with MSC, you're putting a 1.8 millimeter screw in a 2.3 millimeter hole. You have a lot of engagement and tipping of the screw just to engage with the side walls of the expander. And so you're kind of burning out some of your expansion potential with these screws bending. And of course, if your suture doesn't split easily, well, then the TAD heads diverge, more occlusally, right? And the tails stay together. That means you didn't really get much expansion at the tails, right? So if you could orient these TADs, not just parallel, but better than parallel, right? Now you've got the tails divergent, right? And you're engaging in an oblique surface area of bone.
Yeah, you're toenailing it.
Toenailing it, right? And then you can do that. Now you have a little bit better bone anchorage. That's why we see more efficient results of expansion with custom MARPE as opposed to MSC type 2.
And the custom MARPE, was that all coming out of Partners Dental Studio, or were there different labs doing those custom MARPEs?
There were different labs. Of course, I think Partners definitely quickly and easily took the top spot because of how predictable, I think, and how robust the planning was. And then they've developed a reputation and they got very comfortable with certain things. Like, of course, technically any lab with a digital library can do, and metal 3D printing and, access to the little expansion screws can do what they do. But I think they had a knack for designing these things and understanding, these providers are mostly using the MSE ratchet. Well, we got to make the window where they're actually thinking about what tools the clinician has to use in that, individual's palate, and whether them using those tools in that area is going to actually work to deliver those screws in the holes, right? And then, they make those holes 1.85 millimeter diameter so that there's, at least a much more minimized amount of screw to screw housing play in this, right? And that is a very important aspect of making expansion more efficient. We're going to get to how that, goes into some of the FME stuff. But that was an important, I think, advancement, you can call it, right? And there are other labs around the world. There are many labs in Europe and South America that do digital 3D planning similar to Partners.
On MARPEs.
On MARPEs. shout out to Orthodigi in Turkey. They do some great, digital MARPE planning and stuff like that. And there's just some other.
Have you worked with them?
I've had some conversations with them. I haven't done a case with them. I know some of their capabilities because of, some collaborations that I've had, but I haven't ordered an appliance from them. I think we've found maybe some logistical issues with the timing of getting appliances and this and that and whatever.
I wonder if that's who Aisha Chamila uses.
Probably.
She's in Turkey.
I think there's a good chance that she
does a nice MARPE.
She sure does. So I think it's very possible that they are the lab that she uses. So I haven't used I haven't ordered an appliance from them. But they do some really cool stuff. Check out their Instagram.
Cool. So, but in general, the second MARPE Type 2 or Phase 2, MARPE 2.0 was these custom MARPEs where you could decouple the TAD placement from the actual orientation of the expansion screw, and as well as having the tighter socket that the screw sat in, so you didn't have as much play in this between the screw and the housing for it.
Correct.
Are there any other key features of that custom planning that was part of the evolution, the continuing evolution of these expanders?
Well, as far as the planning, I think just really being able to make CBCT such a central element of the workflow, whereas, in the past, we used to pre-diagnose things on the CBCT. We would still look at things on the CBCT. Or sometimes when we didn't have access to CBCT, and we just had two-dimensional images, we would do our best to make skeletal diagnosis from the images at hand. And then basically in the real-time clinical situation, manipulate or, ask our labs to manipulate things to where we thought they should be. Of course, you can see that doing it with the images as part of the design workflow take a lot of the guesswork out of that, right?
I'm not sure I understand that point.
Yeah.
Can you just give me a practical example of the better way of doing it by integrating the CBCT and how that informs the appliance manufacturer?
Yeah, absolutely. So basically there is overlay of surface impression data. That's your STL or digital impression, right? So you have surface data, right?
That's like your iTero scan?
That's like your iTero scan, right? iTero scan, Trio scan, and all that.
That's
right?
the camera when it goes in your mouth and takes a photo of your teeth and your palate and stuff.
Correct.
Actually, lots of photos and then stitches them together.
Essentially, absolutely. And then you have your digital imaging, right? Your CBCT, right? And then, of course, the two are superimposed. There are certain anatomic landmarks, of course, usually just the teeth and the surface anatomy of the gums or whatever that are captured that are used to register those two things on each other.
And is it a separate software where you impose them on each other?
Yes. And labs will have access to different softwares to do that purpose. So there are different softwares out there for that. And again, these are softwares and technologies commonly used in digital implant planning, right? Like Dr. Jaffari uses those things as part of daily practice, right? Where you have a surgical guide to place an implant. You make a surgical guide using the data in your imaging data set. But that imaging data set then has to result in you having something in your hand that you can put in the mouth and guide your implant placement. So the custom MARPEs essentially are the surgical guide generated from overlaying these things together and then seeing what thickness of bone, how do we maybe thread the needle between these roots, right? We got tooth roots on the side, and sometimes you'll see in, custom MARPEs, right? We'll sometimes put TADs in the side, right? That thread the needle between the roots. Well, that's certainly not something you want to guess or do blind, right? And sometimes while you're doing it, it's like, am I really threading the needle between the roots? But you have that confidence and you saw the planning yourself, and you yourself as the provider are being asked to approve that planning, right? So you're seeing that, and then you have that confidence that, okay, if this thing seats on the palate, on the teeth, the way that it was planned to sit, then you know that
I can trust the holes.
I can trust the holes. Exactly.
Similar in a way to Dr. Alfie's pre-printed surgical guides and plates for the way he does his surgeries. Mm-hmm. You go all in on the planning phase.
Yep.
and then you trust what comes out the other end.
Absolutely.
And you basically follow the holes and follow the cut lines.
Correct.
Yeah. Yeah. So continue though. So this workflow.
Yeah. So that workflow basically just, then basically
So your custom MARPE is the guide because it's seated on the teeth.
Right.
So then you cement that, and then now the holes are already digitally planned. Then you place the TADs through the digitally planned holes.
and the lab tells you and provides the TADs that are pre-sized for that particular hole, and they give you a little map saying this TAD goes there
After we've already
approved
and created that plan.
Now, as part of this new workflow, is it the case that immediately in the wake of these custom MARPEs, we started getting more anterior biased placement of these expanders to overcome a common problem that was happening in the early days, which was posterior placement with the off-the-shelf MSE type 2, and the bone is just too thin back there. So people just sort of, was there a reactionary period where people went the other way and they went toward the anterior nasal spine and anchored in the big fat hard bone up there?
I think so.
Can you talk about that?
I mean, that's what I did and do, because, again, you have to understand, we had a lot of failed expanders back in the day, right?
How bad was that? Like, what was that actually like? Like, would you get an adult male come in and you'd be like, well, man, we're really essentially doing a coin toss as to whether or not this is going to work?
I think so. To some degree, we would have to kind of look these people in the eye and say, like, we can't really predict whether you're going to get successful expansion. We may need to do 2 or 3 rounds of expansion. We may need to do this and that. Like, we had a whole spiel that we would have to give because it was unpredictable, right? It was maybe made to be predictable with other forms of surgical assistance, and we'd have to lean on our colleagues to then do surgical cuts for these people to then make them good candidates for a predictable expansion with more primitive appliances, right? Then we got to a point where we saw, okay, when we're engaging the bone anteriorly, well, again, it's not the anterior engagement of bone that causes anterior expansion. It is, again, how the physics of the expander plays out in the subject bone mass when the expander is being activated. So you can have something anchored in the anterior, but having an effect, right? Like you take a pair of weed whackers or something, right? The expression of the force is different than where the application of the force is, right? So if you have expansion that, perhaps primarily is in the place where you have the most mechanical resistance, at least in a vertical screw-oriented appliance, right? Then you have to know that if the palate splits there and unzips to the back, right, then you have expansion in the front and the back. But what are some of the ways that we help it be more equal and not just anterior, right? Well, you got to spread your anchorage around so that your axis of screws is perhaps long enough to engage posterior and anterior bone, right? In
other words, you make sure you add some TADs in the back too.
Absolutely.
In addition to the more solid ones up front.
100%. Right. And of course, the TADs in the back are shorter because the bone's thinner. TADs in the front are longer because the bone is more, thick. Right. And then the other assumption or condition for expansion to be relatively parallel, right, is for the expander to remain dimensionally stable throughout the expansion, right? Of course, if you have an expander whose mechanism is prone to buckling or twisting, then that may affect the parallelism
like
of
mine.
your expansion. Perhaps like yours, right?
You need the appliance to maintain its form.
You need the appliance to maintain its form. And so let's say you now have these barrel type screws, Tiger or super screws, right? As opposed to the MSE type 2 little hex, right? So you got this big, strong barrel thing. But then as it telescopes out, right? TPD and, custom MARPEs both use telescoping expansion screw systems, right? What that means is that you've got basically things compressed into a barrel, and then you're pulling the two tubes out from one another, right? As you do that, you need the whole axis of tube to stay straight, right? Whether it does or not depends on the strength of the tube mechanism that you have at hand, and whether the resistance in the subject bone mass has allowed it to buckle or not.
So right now, just to be clear, you're not talking about the TADs that are in the bone. You're talking about
The expansion screw.
yeah, the screw that is parallel to the bite plane.
Correct. Yeah, or not. If you intentionally don't want to put it parallel to the bite plane because you don't want to exacerbate an asymmetry.
Right. It looks almost like a piston.
Yes, correct. And so you have this barrel, right? And then, of course, if that barrel stays dimensionally stable...
You're calling that a barrel now?
Yeah.
Okay.
I would just, especially conversationally, I think it makes a lot more sense, right? You look at this thing, it looks like a big...
Gun barrel.
Yeah, there you go.
Yeah.
Yeah. And and then you pull this thing...
No barrel.
Toot toot. Asesina the police.
And so you pull this thing out from itself, right? And then, there are times in our custom MARPE cases, right, where, again, a lot of resistance in the palate, and maybe you're activating this thing, it mostly stays straight, but maybe later into the term, you'll see it kind of give out a little bit, right?
As it gets longer and the lever arm gets bigger, essentially.
Exactly. Right? But assuming that it stays dimensionally stable, your expansion should be generally parallel, right? And so that's I think some of what we have to look at with the performance of these things. And then the as to whether as to like how much activation, when do we start to see failure of the barrel to stay really perfect. That I think remains to be studied in maybe some bit of detail. I think that's something missing from the current research on expansion, and I think that it's important to understand that as as you're expanding, and then let's say you get 4 millimeters anteriorly and 3 millimeters posteriorly, or let's say 4 and 2, right? What is the clinical significance of that, right, for that individual? So I think that needs to be studied, right? And I don't think it's been perhaps properly studied with current tools. I think those who say they've studied it and say they have the only solution in the world to overcome the lack of posterior nasal expansion problem are perhaps living a little bit in the past when comparing them to other methods of bone anchored expansion from a few years ago or prior, right? I think now with custom MARPE, FME, all these other things, right? I think we have to revisit that conversation, right? Because and if
we revisit it, what will we find?
Well, I think that we're going to find a nuanced, I think a set of new research questions, right? What is the clinical, to what degree is fan or reverse cone expansion clinically significant? How important is parallel expansion? I think we all sort of inherently believe it to be important because you want expansion in the front and the back to expand the whole nose, right? I think it's common sense. And that's why we want to get expansion in the back, not just the front, right? But I think it's important to understand the clinical significance of that. And I think it's important to understand, what other factors as far as, let's say how far off of, the bone mass does your force application nut have to be, to then not start seeing other kinds of fan shape expansion, or dropping of the, there's all these concerns out there.
But are you suggesting that maybe if we somehow test nasal breathing differences in patients with all sorts of different expansion patterns, that it's not as crystal clear as
yes
some purport it to be, that the reverse
Absolutely.
cone is categorically the best for nasal breathing?
Correct. I think we're not going to find that to be true.
Research to be done.
Right. How would you even study something like that? Using rhinomanometry?
I think that would be one of the things that you could use. Because basically you would need to see some sort of measurable nasal airflow dynamics to know that for sure. But yeah, measurable, nasal gain. So I think you could kind of couple the objective imaging kind of changes with subjective stuff, and of course with other objective clinical stuff not related to imaging, like rhinometry.
Okay. Maybe we should now
Transition into FME.
transition into FME. Yeah.
And I think we'll all chime in here, but
Including Bailey.
including Bailey.
Bailey, tell us about how you developed the FME.
So first no, I'm just kidding.
So we're talking about, this is actually a great transition point, because I think the number one strength of FME is its ability to stay dimensionally stable throughout the whole expansion process, right? We saw more prototypical versions before that look like, hey, how's that thing going to stay stable throughout the whole expansion, especially in an adult male? But with these recent iterations and the current generation of FME, it's like, how is this thing going to buckle, right? And, we have gotten to know the people who have founded the company, and they're extremely passionate about expansion. They've spent years testing and researching this stuff in a lab setting, and then before even kind of starting to think about clinical.
Full disclosure, do you work for these people or
No.
anything like that?
We do not work for
You're
them. We're not.
independent of them. They're simply a supplier to your independent
That's
orthodontic
correct.
practice.
That's correct.
You're not a partner or an investor or anything like that.
Only in only in the sense that we are now, I guess, the only providers. That may change in the coming weeks, but for right now, we're the only providers. We are the ones who've been giving them feedback and sort of experience.
So no, we have no financial interest in this.
But you got the most experience with FME.
Correct.
I'd say so far our experience with Facegenics has been really positive. Extremely detail oriented. Extremely passionate. Then every time we deliver a case, we give them basically an after action report, and every feedback we have, they implement it immediately. Mm-hmm. So each delivery has become even better, more smooth, more accurate, more precise.
Who are these people and why did they become interested in solving this particular problem?
I talked to Cameron about this. He's a patient that has a class 3, and I think that he wanted to apply for himself, and he's seen that there was a problem with the generation of expanders, and he wanted to come up with a solution, and pretty much he wanted to use it for himself, and he's doing that. And he figured out that it has to be really detail oriented, and you just can't just throw something against the wall and make it stick. So that's why everything is so precise, so meticulously planned out, because he saw a need for himself and he wanted to bring that to the population.
But was he like studying the last 5 years of expansion cases and identifying the particular shortcomings of other appliances, or did he sort of start from scratch on with a pen and paper and say, hey, how could I make the best possible expander? Do we know?
I think a little bit of both. I think as part of answering that question, I think he, kind of, had to take a little bit of a survey of different methods of expansion and what the protocol issues are, what the design issues are, and basically tried in real time to develop a product that overcomes some of those challenges.
This is essentially one man who kind of began this by wanting to make it the best possible expander for himself.
Him and his brother, yeah. But for him, yeah, definitely. And so I would say that it's, so far, I mean, our experience has been a patient, like he's a patient himself, and in the future, and he's seen how it could apply in a very calculated manner that's predictable.
What's his background? Is he an engineer or is he just a kind of a savant? who's
I
doing
think
this.
he's an engineer. Yeah.
I'm not sure. If he's not an engineer,
I
he's
think
an engineering savant.
He's a de facto engineer. He's a natural.
Yeah, he knows his stuff.
He does know his stuff. So he may actually indeed have a background in engineering, but I don't know. But if
I think he may have mentioned that to us.
it's a possibility.
And when he went about creating this appliance, and you're saying that the key thing about it is that how did you phrase that again? It's
Dimensional stability.
dimensional stability. So that means as you're entering let's say the 7th and 8th innings of expansion, it's preserving its form and it's not distorting and leading to asymmetries and other types of failures.
Correct. And part of also in the planning process, right? Again, the planning depends on, interplay of, the doctor's prescription and, the planning on the end of the lab, right? So let's say with this, right, they have, what they call kind of like a midfacial alignment protocol, right? So they're looking at different structures of the face. They're looking at the orbits. They're looking at the nose. They're looking at what should be the mid-sagittal plane and other cranial structures and kind of determining a mid-sagittal plane. And they're making sure that the FME in the planning is perpendicular to that plane. Okay. If the FME is perpendicular to that plane, then basically the only variable is, where to place it anterior, posteriorly, right? And then again, that variable is then an interplay of us and them, kind of seeing, hey, this is bone quality and this is this and that, whatever, right?
But in layman's terms, that the mid-sagittal plane, is that essentially the theoretical midline of the whole facial structure? But if there's discrepancy between the teeth and the bone and the pre-existing asymmetries, how do you decide what to prioritize in drawing that line?
Yeah, I think that's a very good question. I think so. Sometimes when appropriate, you'll use the interorbital axis as reference. Sometimes it doesn't make sense to use that as reference if the orbits themselves are misaligned. So you're looking at other cranial markers, right?
But not the teeth?
Not necessarily.
Because the teeth can be moved.
The teeth can be moved. The teeth is perhaps the last thing to look at when you're planning a mid-sagittal plane of the skeleton, right? And so, but you're looking at, maybe anterior and posterior nasal spine. You're looking at, and of course, but if you can see a clear evidence of yaw in that person's face, right, then maybe you're not assigning the mid-sagittal plane as, ANS to PNS, right?
But doesn't this sort of speak to an inherent shortcoming in all of maxillary skeletal expansion, which is dealing with pre-existing asymmetries?
Yeah,
like,
I think so.
Mm-hmm.
I think so. Yeah, absolutely. I don't think that there's a perfect science here. I think, but the fact that we have to now assess and analyze all these structures and that there is a call to do that is progress from where we were as a community just a few years ago.
I mean, I remember asking certain orthodontists just a few years ago what they thought about MSE asymmetry, and they said, oh, there's no such thing.
Mm-hmm. And it turns out to be the biggest fucking problem in MSE.
It was clear to me that it was the biggest problem, but I still can't explain how they could have uttered that phrase. But maybe they meant something different. Maybe they meant like it's the result of screw ups. Like, yes, it happens, but it only happens if someone messes up, a user error, so to speak. Anyway,
I mean, 6 years ago, they didn't think MSC was possible to expand palates, and so for some people anyways.
Fair enough.
Right? And so I think it's an evolving science, and I think that a lot of orthodontists are indoctrinated. Like, some people are still putting up premolars, right? We're clearly on the opposite extreme of that. We don't take out premolars for anything. For sure. Going back to the stability of the actual FME body, I mean, that's something we should probably talk about because it is pretty sturdy.
Yeah, should we take a look at this thing?
Refresh the page if you could.
So we're not screen sharing yet, but let me get a visual for maybe I'll do a screen recording.
While he's figuring that out, if I might add and ask you a question, Dr. Newaz.
Yes, sir.
Have you seen a explosion in popularity or patients coming to you asking for expansion over the past, let's say, 3 years?
I wouldn't call it an explosion, but I mean, there's definitely, I think, I mean, my career is young enough that my whole career has been the explosion, right? So I don't know what to compare it to. It's all I've ever really been known for or did. But I think that, you know, again, as these things become better understood, I think that we may see, and especially if we see a broadening of the applications and better understanding of the aesthetic part of it, I think that's really important, because aesthetic outcomes are very variable, right?
My question was, with people like Ron in the space, pioneer of, you know, putting everything onto the platforms, Facegenics, this could have come in a year or two if it hadn't been brought to the attention of someone like the gentleman who started Facegenics. Like, I think that's an important thing to keep in mind, that this is a progressing field, and the more eyes and the quicker it will evolve. Absolutely. So thank you, JawHacks.
Oh, thank you
for making FME possible.
Thanks for the shout out, you know, but we still got a long way to go. There's a, you know, we're just, sometimes I feel like that's it. We get it now. It's like a good expansion, and then a good jaw surgery, and, you know, maybe some soft tissue stuff to put some icing on the cake when all is said and done. And that's it. We figured it out, you know, like everyone can go home now. We know how to fix airway stuff, but it's like, no, we're just getting started.
And I think that right now, like, you know, if you read like a lot of books about like how Mac got popular, it's like there's a very cult-like following. I think that in this space, it's a very the people that know, but bring this out more mainstream and seeing what benefits it could bring to the general population is, I think, where the true beauty of all this is gonna lie.
Yeah, no doubt. All right, let me start this screen recording. I think it started. I hope it started. All right. As a hedge, I'm just going to get this going too. This will also help us sync it in post.
And this is actually a good time to just kind of give, you know, like a quick intro into how we even became introduced to FME, you know, because, you know, I saw that, you know, Dr. Ting had done a couple cases and, you know, was teaching it, and I saw a couple pictures of it and all that kind of stuff. This thing is interesting. And then that was kind of that. And then we got really comfortable with our custom MARPE workflow and this and that. And then I had a patient, young man, you know, international patient, who, you know, probably one of the smartest 17-year-olds I've ever met, who came to me and said, you know, like, hey, you know, like, this is why I kind of want this new expander. It's called the FME. And, you know, we know that you know about it. I just kind of want to, you know, like, this is some of the reasons I'm pursuing it. And, you know, I think it'll be good for my case, especially given that, you know, now we've demonstrated that, of course, you know, really pure forms of skeletal expansion are possible. And I think that would be good for my case, plus protracting the maxilla a little bit and this and that. And I think FME will kind of lend itself well to my own clinical goals. So here is the phone number for the savant engineer that we're talking about. And, you know, contact him and see about getting hooked up with Facegenics. He's, you know, familiar with my case. So if you just reach out to him and say, like, I'm so-and-so's orthodontist, then he'll, you know, maybe try to kind of get you onboarded or whatever, right? So I contact this guy, and then this guy, you know, refers me to his brother, who's kind of more the business manager of the operation. And the business manager kind of goes over some basics with me, sends me a training kit. I kind of get a chance to sort of put my hands on it and play with the, you know, the FME, just on a tooth model, on a typodont. And then as, you know, as we kind of got a little deeper into, you know, seeing a few more patients who had voiced interest, and Facegenics was getting closer to actually releasing what, you know, was going to be their FME 2.0, if you will. You know, those things kind of collided around a time where, you know, we had our little sort of basket of very early FME patients, right? And of course, that's now translated into a few installs and quite a few more on the books.
Okay, yeah, let's take a look at it.
Let's do it.
What iteration of this appliance are we on? How long has this thing been under development? Like this one right here, for example.
Yep. Well, actually, I would encourage you to back out of that page. Go to the one that is all the way to the right.
Should I go to Babo 23? Yeah. This is Dr. Jaffari's Instagram page. Go to this one.
Yeah, go to that one. Yeah, buddy. And I don't know if there's a way to pause that reel or whatever, but if you look at okay, so if we look at
not paused.
Okay, well, let's talk about it.
Yeah, let's just let it
Let's just let it do its thing.
Okay.
So you're just seeing basically an opened and closed version of the same expander. In the closed one, you can basically see there's 4 little holes there and screws. Those are what's called the retaining screws. They hold the detachable expander module in those little plates. So like the border thing that you see housing the expander module is what is pinned in.
Z,
with
why
the
don't you use the scroller to illustrate your point?
Yeah, buddy. And then actually, do we have a static picture of this 6 tad?
I just took one.
Oh yeah, buddy. Okay. Yeah.
Where did that go? Yeah, I guess I didn't just take one. No, that's the recording. I got you.
Well, we could even just look at this picture in static and at least, oh, there you go.
Yeah, it's not static.
If you go back, just go back to
Instagram sucks, huh?
Oh
Or
yeah,
do
go
I
back to the
suck?
page and just zoom in.
Facts.
Yeah. All right. So let's just keep it there, right?
or you can use the one on the FME. Go to the left, the middle one. You could talk about it from the backside too, if you want.
Oh, I think because those are 8 and 10. I just want to talk about the 6.
Go
real
ahead, use
quick,
the
right?
scroller, Z.
Because there's 6, 8, and 10, right? And so you have, so this expander body right here, this is the FME 6, right? What all FMEs have in common are the 4 retaining screws. That just holds the expander into this sidewall stuff, right? Those are the plates. We call those anchor bodies, right? So the expander is bolted into the anchor body, but the anchor body is bolted into the palate with the TADs. And that's where, if we look at these things over
Are
here,
the TADs not even visible in that photo?
they're not.
Where are they?
They're hanging out under here. So this is the underside.
That's the chassis?
That's touching the palate.
Yeah. And how do I, oh, there we go. Okay. So now as I go over here, right, you can kind of see the little holes are where the TADs go. The big holes are these, right? Retainer screws. Okay. So the FME body, right, in a 6 screw thing, it's just the anchor plates with the 3 TADs on each side, and then the expander module is bolted onto it. In the 8 TAD version, the expander, there's 2 additional TADs on the front part of the body, and in the 10 screw version, there's 2 in the front, 2 in the back.
Now,
And the 10 is on that side.
And then this is,
That's the 10 fully assembled.
that's the 10 fully assembled.
Now, is this... Go ahead, Bailey.
I was gonna ask a question. You know when you put nails in a board, and if you put them too close together, it kind of messes up the wood? Could that happen with the bone?
That's a good question. I think that these are spaced out strategically enough for that not to be a concern. Because yes, theoretically, right? And then you have kind of just weak bone in between, right? So I think that the level of spacing in these is, I think there's, because it looks like there's a lot of holes here, but if you look at the center one and the back one, there's quite a bit of space between there. Also talking about
So the bigger holes are not the TADs.
No.
And is there air between... That thing looks like it's 3-dimensional. It doesn't look like... Is there air between those holes in the palate?
Well, that is a big part of the planning, right? So there can be air between that and the palate if that is what is necessary to align that thing in the person's skull where you want to put it, right? That guide here, right? So this is, you can see, registration of teeth and everything here, right? This is kind of like a little partial retainer, right? You put this thing on the teeth. It has little seating windows, right? There's like little cutouts. I'm going to move the mouse, right? You can see that there's little holes in the teeth part of that. So you can see that your guide went down all the way flush when you put this thing in there, right? So if you see that the guide is flush on both sides, it means that those anchor bodies are going and being delivered to the palate in space where you planned them, right? And then to put the anchor bodies there, of course, in a very flat, broad palate, those are going to be pretty much flush to the palate. And if there's some teetering of the palate anatomy, then those things will still be straight, you know, according to themselves and according to the planning. And then because that, you know, these anchor bodies, they're not just floating in this plastic, they're bolted into it, okay? And they're torqued in. So by torquing and bolting it in, you basically don't allow any migration deviation of those bodies when you're now bolting it into the palate. You're bolting it into the palate with it secured in the planned position. That's the whole premise of FME, right? Put it where you plan it.
But how is that different than what the partners' custom MARPEs do? I thought those are all similarly pre-planned and
correct.
So, going back to what you said before with the oral surgery planning, this you cannot even place this if you are off. If you're doing this properly, this will not be seated unless it's done properly.
Are there certain dimensions in that the custom MARPE can be seated if something is off? If there's a little tilt in it, or is there more? There's more play in the custom MARPE?
Well, I think it's important to say this. The custom MARPE similarly, right? You can be confident that's where you put it if the bands fit flush around the teeth and, you know, the little wings or whatever. So similarly, like this, it's really firm. So it's not that custom MARPE isn't. It's just that FME is extremely unforgiving, right? Meaning it's, you know, it's only going to go in one way, right? And if you bolt these things in, as long as the guide is seated properly, right, then those bodies are being put in space exactly where you put them. Of course, those guides may otherwise be floating, right? But this is necessary to overcome one of what I now think will be, you know, maybe something that evolves with the FME, is that the underside of that thing is not customizable to a person's individual anatomy. That's okay. But so that's why you have to, you know what I mean? Like, and even when it becomes maybe possible to do that, if it should be advantageous to do that, then basically this thing, right, you know, it's still bolted into the guide, but is there some air between this and the palate? There could be, right? So, and does that air matter? Right. Of course, one of the things that we always tried to avoid with other types of expanders was the air gap, right? The air gap means that you're going to be less likely to have a successful expansion because your expander body is, you know, off of the palate.
It gives you an unnecessarily long lever arm, basically.
Exactly. So how do you then overcome that problem, right? And how did Facegenics overcome that problem? Because there's always going to be an air gap if you have a predetermined expander body, maybe placed in space in a customized way like this, right? So you overcome that problem by really making, so of course you have your locking TADs, right? So there's no play between the TADs and the TAD housings.
Yeah, what does locking TAD mean? It locks into the expander body?
Yes. So it locks into the expander body. What does that even mean? It means that the head of the screws itself has threads on it that exactly correspond to the little hole that it sits in.
So now it's not just threading into the bone, it's threading into the expander too.
Yes, threading into the expander, right?
As opposed to just sitting really tight like a piston in a cylinder.
Yes, exactly. Right? So it's threaded in, right? If it's threaded in,
I can't believe Juan Moon didn't get that right.
It's the first iteration, right? Or
it's big. Just, yeah. No, don't get me wrong. I love Dr. Moon, and I went to one of his courses once, no charge, and I brought him a thing of vodka and dark chocolate from Russia. And I love him, but I think he fumbled that one.
Well, here's what I'm going to say.
Even an uneducated carpenter knows that you want a tight. Right. You don't want a gap between your fastener and whatever you're fastening.
Correct. However, I think some of the reason why that play exists, I mean, it used to be maybe clinically advantageous to us to be able to kind of like tweak our, you know what I mean, screwdriver a little one way to try to make the screw tails a little more divergent.
Right, almost like when you like on a TV stand, it comes with the wider screw hole, so you can adjust it a little bit.
Adjust it a little bit.
I get
exactly.
it. I get it.
So there's some adjustability there, and also there's, you know, locking screws have been around in orthopedic surgery for a long time. This is just like, we're talking about it like it's revolutionary stuff. This stuff is basic stuff. Right?
They are on the Discord. They act like it's like a godsend. Like locking tads are like the best invention to ever touch Earth. That's crazy.
So, you know, they've been around orthopedic surgery for a long time. And
just on that point, very briefly, you know, Dr. Alfie's whole thing about custom printed surgical plates, those have been around in orthopedic surgery for a long time too. It's
Correct.
it's new that they're being used in orthognathics. So it seems like orthopedic surgery is somehow on the bleeding edge of a lot of this stuff, and then it gets taken and applied in other parts of medicine.
I think so, yeah. And I think a lot of it is workflows and softwares and this and that, and also just the uniqueness of working in the head, right? You know, I think it's a very different kind of place to work.
And also research, development, money, things like that.
Yeah. There's a lot of money in orthopedics. Is that what you're saying?
And more research, and I think is more prevalent, maybe.
More cases,
more mainstream.
Yeah.
Right. Investments.
Yeah.
So,
you could still talk about the differences in them too now.
So the locking tads, they're the copper colored pieces there on the left, not the things that fasten
correct
the L's into the rest.
So those are different colors. There's different lengths of the tads.
And the other 6 are hiding under this, right?
Right.
And so the locking tads is something that basically, okay, if the tads are locked into the expander body, and then the expander module is locked into the plates, then the whole thing, the whole system must move together, right? And I guess telescope upon itself with no forgiveness, right? Like if the thing tries to buckle, bend, or rotate, then the expansion will fail. Like the thing will simply not turn, right? And that's what they've, you know, did on, you know, sort of outside the mouth testing, right? You can kind of see, right? So it is thought that the, you know, if you get bicortical anchorage, right? You know, so it's basically going through the anchor body, the tad's going through the anchor body, locking into it, then perhaps through a small air gap, then approaching the palate tissue, and then going through the palate tissue into the oral cortical layer and then the nasal cortical layer, right?
So in your palatal sandwich that you were describing earlier, there's two hamburger patties inside of the bun, so to speak. There's 2 layers of bone.
Oh no, I guess it's the bun that's the cortical. So there's one hamburger patty, but there's
the hamburger patty is the spongy bone.
Yes.
And then there's 2 harder layers of bone on either
Correct.
side of that, and there's 2 layers of mucosa on either side of that.
That's correct.
Okay.
You want to pull up the expansion GIF?
Yeah, buddy.
There's like an X-ray.
So that's pretty much.
Is there any Chick-fil-A sauce in that sandwich?
There better be. That's just fine.
Bailey, don't go to my history, bro, please.
in the South?
He just, I saw what you did.
Yeah.
Oh. Is this his Facegenics website?
This is our website.
Oh, this is your website.
What are you, a pilot? Everything is backwards on this thing, man.
Bruh.
What the? Yeah. Okay, is that good?
You want to explain what that was?
Yeah, buddy. Well, basically what you're seeing here is, so this is a CBCT image, of course, of, you know, before and after overlay of, you know, this FME patient. You can see good lateralization of the walls of the nose.
Wow, that's a wonderful opening of the nasal airways.
Absolutely, right? So you can see more black airspace around these gray structures, right? The middle gray structure is your septum, and then you've got the turbinates on either side, right? So this is, just for those of you watching who are perhaps new to palate expansion, this is why, it's not just because you have a nasal septum deviation, you got to go get your nasal septum deviation corrected. Look, the nasal septum stays deviated, but there's a lot more black airspace around it, right? Right. Who do you think breathes better, before or after? Right.
Right. And
so that's the thing. I think this is it's important to kind of think about, like, okay, like I'm not necessarily, like I'm it's basically more about the impact on the air spaces.
Scroll around the deviated septum just so people know what you're talking about. Now, do you subscribe to the theory that septums deviate like that because the maxilla is grown too high and vaulted and it essentially kinks the septum like an accordion, or is that bro science?
I think there could be merit to that, but you'll see deviated septums in people with vertical excess and deficiency. So I don't necessarily think that that necessarily all the way tracks, right? I do think that people with more well-developed maxillas tend to have straighter septums, but not that predictably.
Does this guy have a little sinusitis too on the left?
I guess you could call that mucositis, right? Like, so just from a radiology perspective, I'm calling that mild mucosal thickening in the bilateral maxillary sinuses. That may be not clinically significant, right? It might just be some mucositis, not of clinical concern in the absence of symptoms, or it could be a mild form or manifestation of some kind of chronic inflammatory condition.
It's always good to have an oral radiologist on staff. Just a little shout out. He's probably one of the most intelligent people I know that specializes in both oral radiology and orthodontics.
Intelligent, yes. Handsome,
I've been stupid ever since I got my wisdom teeth out at age 19, though. So I'm just working with what I got.
It was stupid of you to get them out.
It was stupid. I mean, them things I think could have survived.
They could have.
Yeah,
they should have.
That's right, but we're going to be expanding you in the next next week.
Oh yeah, that's right. You've got your own FME install coming up.
Yeah, we're going to live stream that.
That's what the consensus is. Yes, it's been planned and sent, and
so we believe in it. So we're doing it on, and then I'm doing it on my wife too.
Well, in all fairness, I respect it, but also, you got to forgive me, because at the same time, back in the day, all the AGA providers were doing AGA, and they were having their kids do it, and their wives do it, and their dog do it. And that was one of their big arguments, and that was catastrophic. And
yeah,
I don't want to say any more about that space, because if you want to learn more about that, check out my book chapter about it right now. But But I think it's good to put your money where your mouth is, though, for sure.
Dr. Newaz, is it appropriate for me to bring up the front teeth thing? The front teeth thing?
Yes, in maybe in a minute. In a minute, yeah, because that's something. Because that, I'll
keep it at the tip of your tongue, Bailey, right on your front teeth.
Okay. Well, only because. Now, are you just talking? If you were talking about the space, this is the result of slow expansion, that the teeth stay pretty much together, even though the roots are diverged a little bit, right? So that's where your no diastema kind of comes from, right?
Yeah, what are you guys talking about? Can you scroll to it, Z?
See, this is the right side.
So you can kind of see how the edges of the teeth are still touching, right? So there is bone expansion, but the teeth aren't kind of going all over the place, right? This is not a tooth-borne expander. And of course, now we see a lot of MARPE cases that look like this too, especially early on in the expansion, right? Before then, let's say if your skeletal expansion burns out and then the teeth take the rest of the hit, right?
What do you mean by that? The skeletal expansion burns out and the teeth take the rest of the hit. How can an appliance that's not touching the teeth give the teeth a hit?
Oh, no, well, I'm talking about MARPE.
So MARPEs...
When I said that.
Not all MARPEs have dental anchorage, though, do they?
Correct. No, yeah, and that's the whole thing. You could have a toothless MARPE. So it's also not like, oh, MARPEs are, tooth-borne.
So you're specifically referring to MARPEs with dental anchorage that the bone expansion wears out or runs its course, and then the rest goes to the teeth.
Correct.
Kind of like MSE with arms on it.
Correct. And that's really any, I think anything that's attached in a hybrid fashion, right? That has tooth anchorage and skeletal anchorage. Of course, the main force is being applied to the skeleton, but the teeth are going along for the ride until maybe they don't, right? And then they are bearing the brunt of the expansion if the skeleton is no longer opening or yielding to the pressures in the expander, right?
So what happens with FME in that case? It just stops. It's almost like a rusty
we almost
bolt. It
have
just stops.
Yet to see, to be honest with you. I think if I claim to know what happened at the end of FME expansions, I would clearly be a liar, because our first FME patient has not finished expanding. So, you know what I mean? So we don't necessarily know the answer to that question, but like if you look at the expanded form of this expander, right, you can kind of see that it requires that sort of expander screw, also I'll call it a little barrel, right? That little barrel has to be straight and contained in the,
Which little barrel? The one in the middle or the two at the...
Yeah, the one in the middle. The one in the middle.
The jack screw.
The jack screw.
When the FME patient he had 2 different keys he had to use, right? The first one for the first few days, and then you had to switch to another one. Is that right?
Correct. Well, and that's just the thing to turn the barrel, right? But, yeah, so we're basically talking about like in this, right? Let's say that this expansion, this one side of it kind of drifted or rotated a little bit out or something, right? And then you see that barrel thing kind of getting strained, right?
Yeah.
So if the barrel thing is strained, then the appliance is not going to really turn that easily.
Right.
Right?
Right.
Or at all.
Right.
Right. So it's going to burn out. And is
that friction force? What would you even call that?
Yeah, I guess it's you would generate enough friction to then make the turn mechanism fail. Right. Because of rotational drift. Right. Of one or both sides of your expander.
So does FME prevent rotational drift, or does it just stop when rotational drift begins?
Maybe the latter is more how I would characterize it.
But that's still okay, because at least you don't end up with catastrophe, right?
I think it's very beneficial in that regard, that it may help prevent some of those types of catastrophes. I think it's really to see whether it's capable of staying uniform to itself, but itself drifting in the palate. Of course, there are protections built into the design of this thing that try to, prevent that very problem. But it's theoretically possible, but we think that it's very unlikely.
So you're suggesting that the weak link then becomes the screw to bone contact, and the whole thing will shift inside of the bone.
Inside of the bone, yeah. And that theoretically can happen, which is why no expander is perfect today.
And is there anything special about the bone anchorage in this? Are they larger diameter? Are they somehow... are they reverse threaded or some crazy shit that helps them not drift as much as a traditional MSE TAD?
Not in particular.
No?
Not in particular.
You don't put Loctite in there?
We don't put Loctite in there, but we'd be putting that medical Loctite in to close up the Piezo split line.
Nice.
Yeah.
What's that, some fairy dust?
That's that periacral.
No, Dr. Alfie, he has this new product that he puts over the surgical site. It's like an antibiotic growth factor thing. He calls it fairy dust.
Fairy dust.
But he said it's been helping his healing times and reducing infections like dramatically. He swears by it.
Oh, I mean, and one thing about seeing at least every one of his cases that I've seen in person, just the healing. Fantastic healing.
Yes, no doubt.
Fantastic healing.
No doubt. Bring that baby over here.
Bring that baby over here.
The food is ready, but the podcast is just getting started.
Are you serious?
Serious.
Yeah.
Oh, shit. You guys are going to get cold soon.
Baby.
Oh. She has a great stiff arm. It's hard to get a kiss on her. See? You don't even get her. I got you. That's Dr. Newaz and Dr. Jaffari. Hey, Mama.
Look at all these people.
She's adorable.
Oh,
Congrats.
Should we do part 2 or no? We're gonna keep going.
Oh, yeah. No, we're not stopping right now, hon.
All right, babe. Well, I wish that the food was gonna be hot.
That's okay. Yeah. The podcast is hot. That's more important.
That is super important.
Thank you for making food.
Yeah.
Thanks for bringing her up, Lex.
Okay, see you guys later.
See ya. Good baby, huh?
Beautiful.
Very good, baby.
Maxilla, baby.
Oh yeah.
I mean, I would say that the one you put those TADs in and they're all anchored together, it kind of works like the unibody. So when some of the MARPEs, because they're kind of individual, they still have that flexibility within themselves. So sometimes you can see some of those screws deviate more than others. Over here, because everything's kind of locked in together, there's very little, if any.
Right, like when you would take the TADs and you would put one back here and
Correct.
one up here and one there.
Then they're kind of, they could work independently together, but this is kind of, once you screw in everything, it's...
Now, how come they're not leveraging the toenail effect of TAD placement? Especially since that's the weak link. To get more surface area. Is it just because it's...
FME 3.0.
Aren't we on already like FME 6?
I mean, if you do the...
Oh well, those are just the TAD numbers,
Oh, okay.
not the iteration.
Well, the 8 has a little bit of that factor.
In the front, yes,
Yeah,
anteriorly.
yeah. So-
But mediolaterally.
Yeah. Okay.
Mediolaterally, there's
Okay.
none of that.
Huh. I mean, what can you even really do to solve that problem, right? Besides, because if you start going bigger diameter, now you're what Bailey is talking about, you're creating bone fatigue, right? And now you need to make the appliance bigger so that you don't just essentially create a big notch in the palate with all the TAD diameter, you know? It's a hard problem.
I would say, something that we didn't talk about is patient comfort.
Very minimalist.
Very minimalist.
Smooth.
Easier to keep clean.
Easy on the tongue.
Easier on the tongue. Speaking is a lot easier. Keeping it, you get food, it's a lot easier to clean food out. It's not affecting the actual teeth. You're not putting cement on the teeth with the
Everything's rounded.
it's soft. And so, something that we didn't address is literally the person that has it in their mouth. This is a lot less cumbersome, right? Like it's just so much easier to use.
I can almost see myself flicking my tongue on that thing like a fidget spinner. Seriously. It looks so
That
smooth.
would take a strong tongue to actually be able to spin the freaking thing.
No, for sure. And that's a huge factor. I mean, I'm 5 years removed from having something that big on my palate, but I remember though that my tongue would get cut to shit on the screw heads, on the hex. And I would have to plug it with wax. For months I did that. So this is very clever, for sure.
Very well constructed. And anytime we deliver, we do like an after action and we literally give our feedback for the next one. It gets even better.
What are those arrows for? Telling you which way is back?
Yeah.
That's like a tool go on days checklist, right? You can never have too many checks.
Yeah.
Thingies.
The manifesto.
Yeah, exactly. I mean, in Dr. Alfie's surgeries, by the way, I was just shadowing Dr. Alfie. That's why all this stuff is on. Every screw is color coded. Yep. Everything is like, there's a million checks and balances to make sure that stupid mistakes don't happen.
We have like a heat map of how, we're going to be placing each one in the order, the length. So each TAD is color coded for length, and then we verify it on our plan before we start.
Right.
So
right.
it's very precise.
For sure. All right. So I kind of get it. What else is there to say about this thing? I mean, what's
Protraction. We didn't talk about protraction.
Yeah, how do you attach a protraction to it?
You want to pull up the 8 and see if there's.
Even though you can't really see the protraction.
You can't really see it, but
What do you guys think about protraction anyway? What kind of cases are you using protraction for anyway? Just class 3s, or are you guys a little bit more liberal with it?
I mean, I'm the most liberal.
You're a liberal?
Well, the most liberal with protraction, that is.
Oh, I thought you were saying that you were voting for the Green Party candidate.
I will not be. Unless his name's Ralph Nader, fellow Lebanese.
Oh, Ralph. So, yeah, tell me about that.
Yeah.
so the bottom one has the protraction holes on the white screen.
Can you guys...
You can't really see it though.
The bottom one?
Yeah, there's an 8.
Oh, here?
Yeah, well, but like you got to go to the back of the.
You're playing that boomerang, whatever it is.
I was talking about like on the.
The attachment is on the underbody. It's not on the... Yeah, because the underbody is what's bone anchored.
Correct.
So that would make
Yeah.
sense.
Mm-hmm.
And it's not these little...
It's those, not those behind that.
You can't really see.
Right there.
It's in the shadows?
Right there. Yeah, it's in the shadow. Yeah.
If you play it,
Where your mouse like just was.
It's the black back wall, yeah?
Yeah.
So what's there to attach to?
There's a hole there, and then there's a protraction wire that embeds itself in the hole, and then it kind of forms like a handle on the front, and that's what you're pulling from.
But isn't that the back of the appliance?
It is. So you're pulling from the appliance directly, but how do you pull from an appliance in the palate and it come
Unless it's
past
through the
teeth?
diastema.
Unless it's through the diastema, you got to go around. So basically, there's like a little arch wire, right? Going from, so now take any picture of any of those FMEs. Now picture the back surface. It's got the holes. And then the protraction wire is now going back behind the last molar and then wrapping around all the way to the front. Yeah.
Oh, so you still have traditional hooks that come around the buccal side of the teeth,
But they're not anchored to the teeth.
but
they're only anchored to the anchor body.
just the elastic wraps around?
No. So there's like an actual wire that you clip into the FME body. That wire now serves as like the handle. That's kind of the best way I can think of it, right? So now think that
Where does it terminate? Outside of the mouth?
Mm-hmm.
Is it removable
removable.
by the patient?
Yeah.
Really?
Yeah.
How does...
Yeah, you're not going to wear this thing the whole time.
Right. Well, some of these kids...
Yeah.
But
Theoretically, and I think we saw I think like a heat map of the way it puts forces on the bone. So right now we're traditionally using the hooks around the first molars to pull. This is a lot more efficient in bringing the maxilla forward.
why? Because it's less stress on the tooth and more direct force to the bone?
Yeah.
And is it hard for the patient to take the handle on and off?
Of course,
Must be.
and an alternative way to get direct bone anchored protraction is Bollard plates, right? But if you're going to use the expander itself, of course, going straight from the expander module or expander, I guess we'll call it the FME, right? Is one way, right?
Bollard plates where?
Bollard plates. So the patients that I've sent for Bollard plates will typically get them, an anterior and a posterior one. Maybe sometimes just a posterior one. But if you're doing an anterior and a posterior on both sides, then you're going to put the anterior one on the lateral, just lateral to the piriform rim of the nose, right? Just the opening of the nose at the corner. You're going to put one there. And then you're going to put one in this maxillary zygomatic buttress area or zygoma, right? Mm-hmm. And then, so you get some high skeletal anchorage in the back. You get some good skeletal anchorage in the front. And then maybe if this person wants to pull with some kind of control of the vector, you can maybe pull up from the front one and down from the back one, right?
That was going to be my question, is if that is removable, would you be able to go up and down with the force, or would it mess up how it's in? Like, would it come out, or would it be like, do you understand what I'm asking?
I do.
Like what? I guess you would need Bollard plates if you want to go up or down or whichever direction.
Right. Otherwise, you're going to rip up into your gums. Is that what you're saying?
Well, no, the attachment could mess up or remove.
Well, I think that
Maybe not.
I think that remains to be seen. I think we're just slightly a little bit early to see, because there is diversity in the vector that you can pull from this handle. Like basically, there's the FME that's in the palate. Then there's a handle that attaches to the FME, and then there's some kind of external force application, right? So that force application can still be applied to the handle in any which way you want.
And how thick would the handle be? I can't imagine anything thicker than like a very tiny wire be.
I'm thinking of a guitar
comfortable.
string. Yeah.
Yeah, I mean, would it not bend?
Yeah, that sounds.
It's got to be as stiff as hell guitar string.
That's gonna hurt your mouth. Pause. I mean, that's gonna be.
It's a rigid handle. Yeah.
Yeah.
So it gets popped in and out, sorta, like it's a unit.
So would it wrap around the teeth? So it's like kind of thinner in the front. That way, it's not. It's kind of like this. It's not like.
I don't know if it's thinner in the front, but it wraps around. It's almost like a lip bumper. It's like, it's sitting, it's not making any contact with the teeth, and it's only making contact with the inside of the lips and the teeth.
So you'd have to get fitted for it.
Yeah, using your impression. It's custom wire for each individual patient.
Wow.
It's under development right now. It should be out pretty soon.
Oh, it's not out yet? You haven't done one of these yet?
No,
Oh, interesting.
we've just installed the expander that will accommodate it.
I
But
see.
we haven't actually delivered this expansion, like protraction wire, to anybody yet.
And are they going to ship them all with that attachment so that people can improvise? And
That's predetermined by.
So we have to designate like FME 8 or FME 8P, right? P for protraction holes.
Would it be more expensive or not?
Yeah. Because it's a full apparatus that you're getting in addition to the FME.
ain't nothing free in this world.
Yeah.
Yeah, let me get that free lunch though.
Oh yeah, exactly.
It does sound to me though like what you were just saying is that the Bollard plates are sort of the gold standard though for protraction.
But it's a surgical procedure.
Right, you got it, general anesthesia or in office under sedative. You got to flap the gums. You got to see the bone. You got to fasten to the bone. You got to sew it back up. Do a little Lafort cut in there while you're at it.
Loosen it up a little bit.
Unilateral. Yeah,
Drop the maxilla.
It's, I think I personally have seen successful protraction with, just regular, as long as the attachment arms are rigid, right? If you're pulling from the molar hook, that's kind of still my go-to, right? So these are great. These are great additions. One is, of course, incredibly invasive, which is the Bollard plates, but pretty effective. And then one is the FME, which is untested, right?
It's not really that invasive though, if you think about it.
No, it really is.
You know what I mean?
Yeah.
Like invasiveness is all of relativity.
Absolutely.
Like,
yeah.
is it-
No, I
because-
mean, for a surgeon, this is bread and butter, walk in the park, 15 minutes kind of deal. Right?
100%.
It's like, you make a tiny little incision, you just kind of get your access and visibility, you plate this thing in it, and then you close it up.
100%. I'd do that under local.
Oh, yeah. I mean, I think, it's
Pain is
something
relative too.
I think it's something that can be tolerated under local. I'll put it that way. Maybe most surgeons won't elect to do it under local, but I think it's kind of within the realm of what could be done with local.
Well, local sucks for the provider because it just means you're going to it makes it harder for you to do your job. Providers love general, right?
I think providers like some level of sedation, definitely. When you're doing a little more, you don't want your patients to be aware of like, oh, wait, how close are you to my eyeball? Putting that
The
plate
hammer
in.
come out.
But I want to ask you more about
Protraction.
Yeah, protraction in general, because it's such a controversial thing. And, I had Ethan on my podcast recently, and he's been protracting a lot. And his results look like almost like a jaw surgery almost. But the thing I can't wrap my head around is if you're just pulling the maxilla into infinity, what about the joint? And what about the mandible? Because you're not going to stretch the mandibular bone. How do you come to terms with that? Do you just plan for a BSSO, jaw surgery? Or do you only do it on patients that are a little bit recessed in the joint? what do you do?
Very good question. I think it matters what your primary objective is, right? And then again, make all the other puzzle pieces fit however they need to fit, right? So if you will protract because your primary goal is improving nasal breathing, or improving, maybe for some people, a little bit of the protraction is an aesthetic thing too, right? Correcting the under eye deficiency of the midfacial bone complex, right? And, let's say we're bringing this out, and it may happen to be what's needed to correct a facial balance problem, or it may exacerbate a facial balance problem if somebody's a little more class 2, right? Or mandibular deficient.
Totally.
But does that mean that you shouldn't protract? Not necessarily, as long as you have a plan to then surgically correct the mandible. So basically, what I think about protraction in general is I think it is kind of the next frontier of, facial augmentation stuff.
Really? You don't think it's a fad that's already had its moment? You think we're just getting started?
I think we're just getting started. I think if we can figure out how to do it safely, effectively, predictably, all that, right? And it's, I think, inherently a bit more safe than even expansion itself, because it's so gradual. It's just distraction. You just discontinue if it's not, like, you know what I mean? It's inherently a lot less risky than expansion itself. In fact, I see protraction as the essential force modulator externally for the problems we see internally with expansion. Because again, Newtonian physics, one side must push off of the other, and there's no other place that you can apply control to that equation.
Right.
Except extraorally.
This is how we advance non-surgically.
Yes.
Is that what you're saying?
Yeah.
I felt the most breathing benefits when I was doing Headgear. Shout out to Ron. You sent me the crane. That was very nice of you.
I'm going to get in trouble for that now because I'm sending you medical devices.
I don't know what I'm talking about. Never mind.
It must have been done with my prescription.
Oh, yes, exactly. Yes.
I mean, I must have told you to send him.
Yes,
that
you did.
crane.
Indeed.
I think I recall you ordering that.
I think I might have said something about that at some point.
Well, I guess the question that brings up is the market for Headgear is trash.
It's so trash. I've seen some cool stuff though.
Oh yeah, me too.
I've seen some insane DIY headgear stuff.
I was hanging mine from a rope on the top of my door, laying in my bed.
Really?
Yeah.
Damn, man, you had a rope hanging over your bed. Should we talk after this podcast?
Yeah, I closed the door on some rope and made it just long enough so I could lay in my bed and it protract. And I was like, I'm gonna sleep like this, but it didn't work like that. So,
Why didn't it work?
tossing and turning. If you go back even just like a few inches, it like pulls way too much. It's extremely uncomfortable. There has to be something that would be a part of you and you could rotate and move around and it not change the forces. At least from when I was wearing it, the crane was so uncomfortable and you're biting weird. And I think just biting on one side more than the other could exacerbate asymmetry as well. I believe that. So I think there's a lot to be done in the protractive.
So what's the best reverse pull headgear right now? The bow?
I'd say maybe the bow and a modified crane from my experience.
Mm-hmm. Coming soon.
Coming soon? You guys didn't ask me if I wanted to invest? That's messed up, man.
No. See, what we was gonna do is like kind of internally prove the concept and then bring you in.
Yeah, right. That's what they all say. Oh,
we don't want to bring you into a shitty idea.
well, yeah, you're gonna need marketing though. Well, but you guys are starting your own marketing wing, so I'm just gonna be on the outs. That's whatever, man.
But my marketing is better than yours.
All right, I can take my baby. I can take my baby to the food kitchen. No, seriously though.
I'm the worst marketer of all time.
I concur.
Well, that's where Braun comes in.
Yeah, exactly.
I agree with that assessment, Dr. Newaz.
He just makes a rap song about your thing, and then boom.
Boom, bam.
By the way, you can't spell Braun without Ron.
Hey, that's true.
Yeah. And without bro.
Oh, did you know Braun made this shirt?
Yes, I can see by the graphics that that's the Braun style. That is, and the font and everything.
The split, you can see the split.
Yep.
Now is
That's a reverse cone. Wait, let me see that. Oh, that's pretty standard. That's That's like, a good maxillary expansion that is real world, not like, people talk about one-to-one expansion all the way superiorly up to, like the orbits. Do you really want, okay, this is just for everybody, right, that thinks that, one-to-one expansion all the way up to here is good. Some expansion up there is obviously necessary to solve some superior nasal constriction issues. But if you were one-to-one, then you're taking the bottom half of the orbit and expanding it independent of the top half of the orbit, right? If it's just so pure, like that's not what happens in nature, right? That's not what happens in FME or E's or anything, right? It's just, I think there's an obsession for what percentage of the expansion goes up to the, top of the nose. Well, it's probably some percent, but you certainly don't want one-to-one past a certain amount.
Right.
Right. So, yeah.
I'm catching what you're pitching.
Yeah. Yeah. No half eyeball drifting for me.
But I don't get when you say that. I don't understand, because is that two pieces of bone that converge at some suture?
It's a few pieces of bone that converge. Yeah.
And so if the expansion goes too far up the y-axis, only the bottom bone of the orbital is going to move. Is that what you're suggesting?
Well, I'm saying
why
theoretically.
wouldn't the whole eye socket move?
Well, because
and then
the frontal
would increase
bone,
interpupillar distance.
Because the frontal bone won't move with expansion. What part of the frontal bone is moving?
So the frontal bone is this.
The blue, yes.
This is frontal on your shirt.
Fuck. So, right. And so we have the green and we have the blue.
B, go get that little skull diagram.
That's actually what we made that design from, was that skull.
This is that skull. That's the original skull.
There you go.
That's the one.
That's the one.
But
so what he's saying is that one-to-one is not logical or possible.
Dr. Jaffari, you take the skull because actually, Z, you don't have a zoomed in shot. So
frontal bone.
Yeah, hold it up and hold it closer to your body, because otherwise it's going to be out of focus. Yes. So now using that, explain your point about why perfectly parallel expansion up the y-axis, or the good ratio of expansion going up the y-axis rather than it being conical along the y-axis, is actually not as good as it's cracked up to be.
Oh.
Yeah, I'm asking either of you guys.
Oh, okay. Well, and it's not, again, it's not a matter of, I think, good or bad. I think it's really more of just realistic, in nature, right, you are going to get, with a palatal application of force, a little bit more at the level of the mid palate than you are at the superior part of the nose. And that's okay. You can get a very high quality, clinically measurable improvement in nasal breathing, right? With, expansion that doesn't go up one-to-one. And I just use the orbital thing to illustrate that that's not feasible or possible,
because there's sutures,
or desirable.
There's sutures,
and you're increasing the lower half of your eye socket
without moving the upper half of the eye socket.
So you're like.
Now, do you think that's what explains why some people get ocular issues with palatal expansion, with skeletal palatal expansion? I've heard reports. It's very rare. It's definitely not
extremely
something
rare.
I hear.
It's a very exotic but possible thing, right? And I don't think it's necessarily that phenomenon, but I do think, obviously, you can see the maxilla and the zygoma, right? And the, basically that whole lateral part of the nose, medial part of the orbit, right? Those are all structures affected by expansion. So you can imagine how moving those structures might, in some cases, maybe impinge a nerve or displace a this, or, And
that's why also going slower is probably wiser.
Right. So that if you do start impinging on a nerve, you have time to react.
Correct.
Now, what was I going to say? Yeah, but to your point, though, in nature, if the tongue is the palate expander, and if I start going off on a bullshit bro science tangent, just stop me. But if the tongue is the natural palate expander, it's going to kind of expand in this conical way. It's not going to it's not going to split your face in half. You know what I mean?
This is not going to do that.
Right.
Yeah.
So interesting. But the point that Dr. Casey Lee makes a lot, though, is that you do want some expansion
Yes.
up the y-axis in the back.
I think he's right about that.
Yeah.
I think he's right about that. I think that, again, I am as much of a fan of posterior expansion as anybody else. I just don't think it's talked about the right way. That's what I guess. But I think if somebody does an analysis on everything I've said today on this podcast, I think they will see that I'm basically supporting the fact that, okay, there's an importance for posterior expansion. I think some of the hype or desire for posterior expansion is warranted. But if you talk about it in a vacuum or in a very dichotomous way, that's simply just wrong and short-sighted, in my opinion.
You look at the big picture, basically.
All right. Are there any other comments you want to make about the FME? So tell me about cases where the FME might not be the most appropriate type of expander that you would use. When would a partner's custom expander or similar be more appropriate?
That's also a very good question. I think that, the way that I'm navigating this myself is that I think that both custom MARPEs and FMEs are fantastic expanders. I don't, and so when you say like latest and greatest, it's definitely latest and it's definitely greatest in some regards with some aspects of its engineering and, physical features. But it doesn't necessarily make it the greatest expander, making MARPEs extinct, right? MARPEs definitely have a place, and they're still my go-to expander for most people who need a modest amount of skeletal expansion, right? It is, very predictable. It does have less factors in the workflow. It is more customizable. So the advantages, I would say, of MARPE are probably just the following few bullet points. You can customize the underbody of the expander framework to conform to an individual's anatomy.
If they have a torus or something.
Sure. Yep. A torus is a very good example of that. Right?
Or maybe a high vaulted narrow palate.
Correct. Right?
Or asymmetry. So some of the things that we design is we can actually angle the way the body sits to possibly even decrease a cant and things like that. And we have had success with some of our patients with that as well.
Wow.
We're fixing the asymmetry with the custom MARPE.
Wow, that's
So instead of making it worse, we're actually trying to and designing it where we're actually helping their asymmetry.
So if the palate is like this, you might place the appliance like that and try to
Stuff like that. Yeah. Right. And so
as long as that's happening in a context of it being appropriate in the rest of the skeleton. We talked about the eyeballs, right? So yes. But yeah, those are the types of, right? Some people have depth asymmetries, right? Malar or zygomatic prominence is greater or lesser on one side than the other. Well, you might be able to adjust for that in a custom appliance. I have some patients that have very pinched in nasal bases, right? What does that mean? It means the nasal cavity may have a bulbousness or a width, but that little part of bone that's actually available for bone anchorage at the top of the roof of the mouth and at the base of the nose may be very narrow or thin. You need to thread the needle any which way you can. And, have that, like if I'm predetermined to where my TADs are going to go, because that's what comes in the framework, I may not choose that device, right? I may choose something that allows me to place anything wherever the heck I want.
Do you ever still use MSE type 2s?
Yeah, I use them for teenagers, maybe even some like young adults. It's very, you know what I mean? But yeah, mostly kids now. Kids are great, candidates for MSE type 2.
What about surgical assisting, these FMEs? Do they require less surgical assisting, or do you still do the Piezo assist just for good measure, just to really pave the way?
I think everything you said is correct. I think we are doing it for good measure now because we're early in FME. We obviously have yet to see, what we can get away with or without surgical assistance with a lot of these FMEs. But of course, also given some of the practical context in which we're doing FME, of course, because we don't have some of that collateral bracing of tooth anchorage, because we don't have some of the other, what we've now grown to see as luxuries with other kinds of expanders, we want to now just eliminate any variables that we know might contribute to failure, right? So So that's why we're doing, bone cuts on almost everybody. But I do contend, and in general, I'm somebody who's actually tried to push the limits of what is possible without the corticotomy. And
Mariana Evans is big on that, pushing that limit.
Absolutely. And
I think it's good because it forces you to keep doing better MARPEs.
Absolutely.
Or better expanders. It's the ultimate litmus test.
It sure is. And I mean, these days I've actually gotten away from doing, corticotomies on almost all females in any circumstance, right? Again, we're going to do a few just really partial kind of, baby corticotomies for some of our female FME patients coming up. But
I thought you believed in equity.
Well, the bone is not created equal. We know this. We know that the bone is not created equal, right? Everybody has equal rights to expansion, though. So holler at us if you're male or female. But
it's just another shitty thing that men have to deal with. They have to get the Piezo knife, man.
That's what I'm saying. Yeah. I mean, more often
Fight
than
wars.
not. Yeah.
Build skyscrapers.
Yeah.
Take the Piezo knife to the dome,
Exactly. Yep.
Hey, can I ask you a question about the Piezo knife that maybe because you have an engineering background, you can help me answer? How does the Piezo knife...
I don't have an engineering background.
I thought you had an undergrad in engineering.
No, I do not.
Oh.
Yeah, I'm
your father.
My father.
Your father's an engineer, so that's an engineering background.
Yes, that's an engineering background. But I'm not like even 1/10 as smart as that man. I mean, he's on another level.
He's a good man. He's a professor at
professor at Wayne State University in Detroit, Michigan. Yep.
I met him once. Good guy. Shout out to your old man.
Yeah, buddy. I'll let him know you said what's up.
So, but how does the Piezo knife not cut soft tissue, but it cuts bone? It's like magic.
It's a frequency thing.
I ask because when Dr. Alfie was going in to finish off the maxilla at the pterygomaxillary area, he would just take that thing and just go with it, and I would be like, "Whoa, but he'd be like, "No, man, it won't cut soft tissue. It'll just cut bone. You can do that."
It's basically the noodle theory, right? Like you have, let's say you have nerves or blood vessels or whatever, right? And you put this thing in there. Well, of course you're putting something in there that, of course, like when you're doing like a spinal tap or something like that, right? Like you're probably not going to hit a nerve because things kind of move out of the way, right? So for looser soft tissue vascular structures, that's kind of part of the phenomenon. But the real inherent thing in the piezo is the frequency, right? This is basically a frequency modulated. You won't actually see the piezo tip like shaking around. You turn it on and the thing looks still. So how does it even cut? It's like a super ultra high frequency kind of thing.
Is it actually moving and the eye just can't see it? Or does it not actually move?
Yeah. If you touch it,
it's got to be moving.
Yeah, it's not just emitting sound.
But you can put it on your finger. It's not going to cut your finger.
Come on, man.
For real.
But how does it cut through the palatal mucosa?
Well, okay, if you apply enough force, you can pierce it just through brute force. But that's why we use a 15 blade
to go through the
and
soft
make
tissue
a
first.
initial soft tissue incision and then do the piezo.
Because you get a finer cut instead of just pushing a blade through it.
Exactly. Because if you just push the blade through it, then you got to push harder. Pushing harder creates heat. Heat creates, yeah. So,
is that your own innovation on Piezo Surgical Assist?
I don't think it is. I mean, it just made sense to me though that like if this thing is not meant to cut soft tissue, let me cut the soft tissue and then get the hard tissue with the hard tissue cutter and then close out the soft tissue.
So you're telling me I could take a Piezo saw, turn it on, and I could go in it, and if I don't push hard enough, it's not going to cut?
Yeah, that's correct.
That's nuts.
No, it's gonna get hot. It's gonna get very hot.
It's going to get, it might burn me.
Yeah. That's why you need a lot of saline.
It's not going to pierce the tissue without like brute force.
Right. Did you know that, Bailey?
I had no idea. That's insane.
It is insane.
I mean, if you're feeling frisky, just go ahead and get a Piezo. Put it on your what's it called?
Take that to the test.
That's crazy, though. Mr. Piezo must have made a lot of money on that thing.
Yeah.
Right?
Yep.
Is he a Mr. Piezo?
I don't know.
Is it not a Mr. Piezo? Is it?
We use Piezo in different types in dentistry too. So, for example, if you get your teeth cleaned, you can use what we call a Cavitron or a Piezo, different version of ultrasonic cleaning to clean your teeth.
All right. I guess it's the noodling thing kind of makes sense. It essentially just wiggles its way around the soft stuff, kinda.
Yeah, pretty much. And it's well, and it just doesn't cut it. Like the frequency does not allow it to damage soft tissue.
Okay.
You know.
But somehow bone responds differently to that because of its rigidity.
Correct.
Okay.
Yeah.
All right, we'll go with that. The big question, do I need expansion prior to MMA surgery? Riff on that for me.
That's a great question. I think we should both answer that. I'll just give a quick blurb, which is basically, what is like literally everything else we've talked about in this interview. I mean, you have to really look at the individual situation and know what your objectives are. So if what is necessary to put an individual's anatomy, teeth, bones, tongue, airway, nose, in a position that supports your primary objective, which is curing a sleep or breathing problem, right? Then what needs to happen? Sometimes expand and then do the surgery. What pros and cons are there in doing that? Well, of course, expansion necessitates that, you're doing something pre-surgically. Maybe you're doing, I think you're doing something a little more conservative to assess the potential therapeutic yield of that intervention before committing yourself to a larger intervention.
You're staging it out. You're not going all in.
Not going all in.
I get that part.
So
yeah.
to me, that's a big benefit of going that way.
So you're saying it might help you avoid surgery completely?
In some cases where it's otherwise appropriate, otherwise feasible to avoid surgery, yes. There's some cases it's going to be a slam dunk surgery.
Those are the ones I'm talking about. The ones that they're already dead set on doing the surgery, but they're just wondering if they should do the expansion first.
Well, what about the wisdom teeth? If you still have your wisdom teeth and you expand, then that could potentially help the wisdom teeth come in, and then would you have to remove them for jaw surgery?
I asked Dr. Alfie if he's ever done his jaw surgery on someone who had their wisdom teeth. He said it's not, no, because they're right in the way of the BSSO cuts, right? Especially on the mandible, right? I mean, because one thing I learned during watching Dr. Alfie was that the hardest part of releasing both jaws essentially is down here, and here. It's like tough access and you're kind of blind in a way. So you can imagine the catastrophe that would be if there was a wisdom tooth back there that was in the way. So I don't think you're keeping your wisdom teeth if you're doing jaw surgery under any circumstance.
That shouldn't be the expectation, correct? There are.
Have you ever seen it? I've never seen it.
I have seen it.
You have seen it?
I have seen it.
Show us the cases.
Actually,
Show us the proof.
Yeah. No, I have.
No, I believe it. Hey.
Although one of the cases I'm thinking about was somebody who had 4 premolar extractions. So maybe the wisdom teeth were in a second molar position, right? But anyways.
Hey, have you ever seen a double jaw on someone with 32 teeth?
I mean, come to think of it, maybe not.
Right? That's what I'm saying. Dr. Alfie hasn't, and he's done a lot of jaw surgeries.
No, I have, but then they became a 28-toother because of the surgery.
There you go.
I guess that's the sacrifice,
It's sacrifice.
Long term, you don't know.
I mean, you're getting bones like way forward in your face. I mean, at that point, it's okay to,
Sacrifice the pawn to get the queen.
Something like that. Yeah.
Yeah.
Well, what if you're I know we talked about this briefly, but what if you're like an MMA fighter or a football player? Jaw surgery can't really be an option because if you get hit wrong and one of those plates shifts or moves, like that's pretty scary.
Also a very common question that I'm seeing more and more often, but Dr. Alfie said Dr. Alfie's brother is into jiu-jitsu and is considering jaw surgery, and that's his hang up. He's like, I don't know. But Dr. Alfie's like, dude, 6 months and you're good to go. 12 if you want to be safe, because essentially you get to a point where you can remove the plates and the bone is there.
It's healed. Really? It's fused.
What do you guys think?
So going back to the pros and cons of pre-surgery expansion, I think it's a little bit more predictable orthodontically, and also the cuts if you're like some of the cuts may damage the teeth or put the teeth at a greater risk too.
The Lafort cuts, or specifically the segmental
Yeah.
Lafort cuts.
Mhm.
Yeah. Yeah, Dr. Alfie would, whenever someone was considering segmental, he would say there's a little bit of an increased risk to the teeth.
So, and then orthodontically, it's probably more predictable.
So then it's okay. Well, why not just do jaw surgery? What are the benefits of expansion?
So,
And I feel like you could just touch on it.
This is the opposite. So, I mean, you could get relief much sooner, possibly, right?
So the question that I'm wondering is the maximum net nasal breathing benefit. Yes, obviously you get nasal breathing benefit from expansion. Yes, you get nasal breathing benefit from jaw surgery. Maybe we can talk about the anatomy of that in a second. But is the maximum possible nasal breathing benefit jaw surgery plus expansion? Theoretically.
Theoretically, sure. Yeah, because I think there are parts of the nasal cavity. This now ties into the anatomy of the question and now the actual anatomy that, expansion effects are broad, more broadly applied in bone anchored expansion than they are in jaw surgery.
Can you dive a little bit more deeper into that?
Expansion goes higher up.
Correct.
And of course, you're getting, changes in structures that are above the osteotomy line.
So that's really the crux of it, is it's what's happening above the osteotomy line.
Correct.
Oh, Trump got shot.
Shut the fuck up.
Trump got shot in Pennsylvania.
Come on, man.
What?
My phone's blowing up.
Really? Are you serious?
Yeah. Let me just, I'm getting like a bunch of text messages.
I'm
about it.
gonna go on Google News real quick. Trump rushed off stage after gunfire. Gunshots reportedly fired at Donald Trump. Well, it doesn't sound like he's dead.
Well, I can't wait for Kamala Harris to be our president. Maybe we shouldn't put that in.
It's a neutral comment. Well, I don't see anything conclusive here. So in the absence of anything conclusive, let's jump back to this. So doctors Jaffari and Newaz. So this is an ease. All right. And it's a before and after. So what we're really talking about is, so the osteotomy is basically right here. Even if it's a little higher, it's never going to be any higher than that in a double jaw, right? And so if this is the high, this bottom green line is essentially the highest you're going to get expansion with the double jaw. But the expander, you can see change higher up.
Correct.
Up to basically from this line up is what you get with the expander.
You can even see lateral migration of the frontonasal suture area. Look at that, right? You see how it kind of swings out?
I don't see that. Can you point that out?
Yes. Check this bone out right here, right? So you have just a little bit of change up there.
Yeah, which is scary because sometimes when that thing budges, you get leveling problems with expanders, right? You get one side of the face will drop because of that.
Exactly.
But this is clean.
This is clean, and this is a modest amount of expansion, right? You don't see that happen in anybody who's, look at this change, right? You're going from what, like 19 millimeters to 20. There you go, 19.3 to 20.6.
I don't think this treatment is complete.
Correct.
This is early stages, but I think it's a good visual for seeing changes upstream of the osteotomy of your typical double jaw.
Exactly.
So, but then we get to the question of how much does a patient really experience that difference? And like because what patients are doing is they're doing a cost-benefit analysis as to whether or not they can skip, especially patients that are orthodontically already ready for surgery. They're like, hey, can I go in and get an 80% fix for 20% of the effort by just doing this double jaw? It's predictable, it's precise, it's gonna address the AP in addition to the transverse. But the only thing that I think people are unsure of is, am I gonna miss out on the nasal breathing benefits of the expansion? And is that gonna cause me to continue mouth breathing? And is my jaw surgery gonna therefore be unstable, or am I otherwise gonna be dissatisfied with my nasal breathing even after the jaw surgery if I don't do the MARPE first? And I guess you would have to say it varies. There's no way of knowing, really. Is there any way of predicting that?
Not until we have more data, more AI modeling of what kind of, like, let's say you input a skull into futuristic AI program, and it kind of, predicts perhaps where this person's expansion is likely to succeed or fail, or how prone they are to symmetry problems, this, that, whatever. Then maybe, but until then, maybe not.
But if you were a betting man and you had to bet on the best possible approach, maximalist approach,
Bone anchored.
for getting,
first.
bone anchored first. That's always the safe play.
Yeah.
So for someone who's,
especially because you can correct for the deficiencies that occur within that in the ensuing surgery.
right, yeah, you can go to town with it, and if you get an asymmetry, you just,
Fix it there.
right.
And then, I mean, I'd say for a lot of our patients, it's staged. So even if they're not fully committed, once again, it's kind of, you're not going all in. You can see what kind of benefit you get with the expander first.
Right.
And one that's cheaper, it's less hassle, recovery time, etc. All those benefits too. Less
Right.
risk.
Right. Now, one other thing that I want to get your opinion on that I saw Dr. Alfie do, it's kind of his signature thing. I don't know if other surgeons do this. Maybe you know. But one thing he does is after he plates the maxilla, he takes his saw and he just cuts out a big sliver of bone from right here. Because what I was seeing, and he would pointed this out to me on every patient that he did this to, he's like, look at all these bone spurs, look at all this extra bone mass that's protruding here. All of this is unnecessary, and it's inhibiting the nasal aperture. What do you guys think about that?
Yeah, I mean, it sounds like to me a sound thing to do if that's indeed, if you have too much bone mass there. As to whether how standard or signature it is, I don't necessarily know. But is it a sound thing to do? Yeah, absolutely.
You could see that anatomically potentially improving nasal
Correct.
breathing.
Yeah.
Because the width of this bone right here,
Yep. Is your aperture.
that's your aperture.
That's your aperture. And then,
That's the tunnel entrance.
correct. And then you just have to think about, again, how your soft tissue is going to respond to that. So person's, alar base going to be too wide. What kind of suture are you doing to manage said width issue in the alar base? Like all that kind of stuff, right? So there's a lot of factors to consider, but alone, sure. Like if you have redundant bone there that you don't need.
Little bony
It sounds-
projections.
Yeah, correct.
Yeah.
It sounds sound to me that one
Yeah.
would remove that to improve the aperture.
Yeah. How would
It's basically essentially a lateralization of the nasal wall.
you mean it's equivalent to an expansion?
In a way, yeah.
Right?
At least of that particular area.
Right. That's what I'm saying. I think that option is attractive to a lot of people who just want to get in, get out, and get an 80% fix.
I think there's, again, merit to that as well.
Yeah.
And that's why, I mean, when we plan these things, you have to really talk to the patient, and there's no one size fits all. It's finding out what benefits they want, what's their timing, what their lifestyle is like, it's not, you have to, and nothing's in a vacuum. It's really getting to know the patient. And I'd say one of our combined skill sets is really listening to our patients and understanding where they're coming from. We really pay attention to that. Right. And trying to figure out what works for their lifestyle, for their personality, for who they are, you know, and all those other factors that come with each individual.
Totally.
You know, and I think that's one of our skill sets.
Totally. I guess what I'm saying is, how do you manage what a patient says they want and what they're willing to do with what's actually going to get them the expected result? Do you know what I mean?
Mm-hmm.
Because I feel like sometimes skeletal expansion and jaw surgery is just, especially jaw surgery, is so far out of the paradigm of patients as they enter this space that it's like, you see these patients and you just know that they're retrognathic. You can just see it, you know? But like, you can't just say to someone, yeah, man, to get what you're looking for, you're going to need to do the double jaw. Do you do more listening than talking? Do you never propose something that they don't mention first? How do you walk that fine line with some of these procedures that can become very invasive, so to speak?
Oh no, we mentioned those things without them asking all the time.
You kind of have to. I mean, that's your responsibility, because, you know, when we're taught in school, I mean, an option is to do nothing. That's an option too, right? And so we have to discuss, like, you can choose not to do anything, or you can do the most extreme, right? And so we try to present as many options as possible, and then kind of see what their lifestyle requires and what they need,
Right.
and then kind of figuring out what's the good balance for that patient.
Right. How do you guys coach people on choosing jaw surgeons? Do you have one person that you can rely on? Do you have what's your decision tree?
I have a trusted few, you know, like, I mean, and, you know, again, the disclaimer for this comment is that there are very good jaw surgeons everywhere whose names don't float around from either our recommendations or in the echo chambers. There are good jaw surgeons everywhere with very good surgical skills, experience, this, that, and some of them have, you know, been fortunate enough to, you know what I mean, like, do some good work for patients, and we know, you know, you see what I'm saying. So I, you know, we all will have our preferred surgeons because we know who can do what, who has what capabilities. I think really when it comes to the patient, choosing a surgeon, because it's not uncommon that perhaps, you know, because of a logistical or travel or cost issue, we have to give names of 2 or 3, right? If we give the 2 or 3 and all other things being equal, I will tell them, go with who you feel understands your problem the best and who you think, you know, what I mean? Like, let's say if one of them is willing to share a plan with you and the other one is not, and that's important to you, then you might know who's a better fit for you, right? And so forth. So I think that those are some of the things. But I think, you know, of course, orthodontic surgeons, this is the kind of thing where, you know, you want somebody who does a lot of them.
Time out. Do you pronounce the G or do you not pronounce the G? Do you say orthognathic or do you say orthognathic? Because I just added the G recently, but I'm having doubts.
I think I tend to skip it.
I do too.
Orthodontic.
I say the G.
You say the G? Bailey?
I don't even say it because I don't know.
Isn't there 2 G's in there?
I think it's no G.
Orthognathic? There's 2 G's?
There's 1 G.
1 G?
I thought it was a silent G because, you know,
I thought so too.
like gnome.
Yeah. Nathic, like nathological principles. Right.
Yeah. We need to standardize that. Well, we're not going to standardize that. One thing we can standardize is naming nasomaxillary expanders, because the way you guys use the term MARPE is specific to partners' custom MARPEs, but I use MARPE as an umbrella term to refer to all nasomaxillary
You are more
expanders.
correct. We just had to just refer to it as that for this discussion because
Partners is too much of a mouthful.
Exactly.
And there's also
It's
other custom MARPEs.
correct.
Okay. All right. So I don't have to change my whole ebook.
You know, the TPD is technically a MARPE. If you think about it, it's not in the classical sense. Of course, MSc, FME, and partners MARPEs and other custom MARPEs are all MARPEs, right? The TPD is not really a MARPE. It kind of technically is if you consider the tiny little anchor screws to put the little plates into the, you know, side walls of the bone.
Those are micro implants.
Those are like kind of micro implants, just kind of like little fixation screws. So maybe it's not quite like MARPE, but it's, you know, it's some kind of bone anchored.
You're putting a fastener
appliance
into a bone.
Yeah.
Yeah. All right. Anyway, that was a tangent, but getting back to, so let me just pose this to you. So Anil Rama said that when you're choosing a jaw surgeon, just focus on aesthetics and let the functional cards fall as they will, basically. Like, because you could do, so for example, when I do my, you know, coaching sessions with clients on weekends, they will have seen 4 different jaw surgeons, all the usual suspects from the echo chamber. And you'll have one of them recommending 14 millimeter advancement on the mandible, and one of them is recommending 7. So it's like, that's radically different. How do you, you know, 2 top world-class experts suggesting such radically different things? Obviously, one of them, the way I read that, one of them is erring on the side of a more conservative, natural-looking aesthetic that's not going to stretch things or cause the chimp lip, that you can just tell that they almost look like a mannequin after, because it's such an aggressive movement. The skin doesn't react well to it. And one of them is erring on the side of maximizing the airway. So do you agree with Anil Rama that you should always err on the side of aesthetics? And because there's no guarantee that 14 millimeter advancement is even going to solve your sleep issue, but at least you can know that you're going to look good after? Or do you...
I mean, I'd say, once again, I mean, when we do anything, it's patient specific. So if a patient's more aesthetically inclined, then that's something to consider. If a patient's like, hey, I don't care what I look like, I just want max, then that's true. You know what I mean? So, we see this all the time with our patients, right? And so we kind of have to figure out what's the best solution for them individually. Right. So even to answer that question, I would say it's debatable.
It all goes back to what the patient wants and what
needs,
their psychology,
correct,
their life circumstance.
Yeah. Mm-hmm.
Totally.
And both of those surgical plans could be sort of anatomically well within the range of responsible treatment. Because it's one thing to be irresponsibly, one way or another way, right? But then it's, I think if it's not breaching some sort of standard of care issue to make a certain change, it's possible that both the 7 millimeter and the 14 millimeter people are right.
Do you think there's a better chance that the 14 millimeter expansion is going to experience a more significant airway benefit if you were in Vegas?
Absolutely.
Okay. Because believe it or not, some of these top surgeons in the echo chamber will say, no, you cannot say that the bigger expansion is going to be more of an airway benefit.
Well, what's the relative benefit? I mean, are you tapping out and you're just doing more expansion?
Do you think the curve flattens at the top?
I do think it flattens. It's not like,
So are you compromising aesthetics so much that you're getting minimal benefit by going 7 more? I mean, those are questions that individually have to be answered for that patient.
And maybe we need more data also to know about this, or is it really patient specific? It has to do with the shape of their airway.
All of that.
All of the above.
It can't be generalized like that.
And then that's why, like, on the talk spaces, a patient will say, "Oh, this applied to me." That doesn't mean anything to you or you or you. It could be for the one individual.
Totally.
And so that's why you have to have a surgeon that's going to communicate well with you, hear you out, listen to you, show you the plan, right? And if they're just kind of shoving it, you got to go this route, I probably wouldn't suggest that for most patients.
Yeah.
Especially if they want that hand holding and that, interaction.
Right.
And that's kind of where we come in, is we know that as providers, we listen to our patient. I mean, to the level where our staff gets annoyed because our consults are very long.
Right. I hear that.
We literally will answer every single question in 7 different ways. And, they ask the same thing 7 different ways, and he'll spend hours talking to them.
Yeah.
And then, there's no other way to ask the same question at that point.
Right. Yeah. They do tend to ask the same questions over and over in different ways. Dr. Ting made that observation as well.
And he's still patient enough where he'll still answer it.
Right. He is. Dr. Newaz is an extremely patient man. I can vouch for that.
Same.
Handsome? Not so much.
Come on, Ron.
Maybe after my FME.
After the FME.
Exactly. After his FME.
And I'm with all that new oxygen, my cortisol levels are going to drop. I'm going to lose like 60 pounds. And then I'm going to hit the scene.
The ultimate biohack.
I still love my wife. But
Ladies, no ideas. The man does have a ring on his finger. All right. Well, I don't think I'm going to make it to that party.
Hey, the party was here.
No, we gotta get you into that party.
7 p.m. The grill is shut down. The party's over. It's all right. I'm going to have to mail him a nice gift.
Oh no.
It's all right.
Oh, we're sorry about that.
I'm the one who kicked. It's on me. You know. We said we were going to do an hour. I don't even know what we're
I think we're
at.
at hour 3.
Two and change.
Almost 3.
Yeah.
Oh wow.
The camera's still running, so that means we haven't run out of hard drive space, which is good. So. All right.
Well, thank you for having us.
Yeah.
It was an amazing change up to our schedules, right? I mean, we don't normally take off, so
No, yeah, you guys have
thank
the
you for being
weekend off.
really hospitable hosts, you and your wife and your baby.
Oh yeah, I'm glad you guys got to meet the baby. I think we're gonna go have dinner now, right?
Yes, we are.
With the baby,
Yeah, some of Ronnie's wholesome foods.
cattle.
Yeah, cattle with some beef tallow and
Some bones.
some bones.
Yeah, it's cattle, and then
some jaw developing
butter.
kind of food.
for dessert, we instead of putting ice cream in a cone, we just put beef tallow.
Yeah,
All right, well, Dr. Newaz, Dr. Jaffari, Bailey, aka Braun,
And Jolly.
and Jolly.
Jolly.
Hashtag Jolly. So
We'll definitely follow us on Jaw Complex.
yeah, how can people reach out to you? How can they contact your practice? How can they follow your work? What are all the contacts, guys?
They are these, and I guess when I say these, you can maybe overlay links to our office numbers and Instagram.
And if not, link in the description.
link in the description.
Okay.
Yeah.
Okay, but if someone wants to become your patient, is it pretty simple to call and make an appointment?
Yep, just go to teamdental.com and yeah.
And where do you practice out of, roughly? What's your
The whole
domain?
Eastern Seaboard.
So we've got, so I'm Williston, Vermont, New York City, and Ponte Vedra Beach, Jacksonville area, Florida. And we overlap in New York and
New Jersey and Pennsylvania.
And you guys will be at MUCON on August 17th?
I think I'll have to be there because I made a commitment to speak. So
Wow.
yeah.
Dr. Jaffari?
We'll be there.
Bailey?
I will be as well.
You'll be in the audience?
Yeah, I'll be cheering them on. Hey, hey, hey. I'll be cheering both y'all on. I'll be like with signs and everything. I'm like y'all's biggest fan. This is like crazy. This is so wild.
That's awesome, man.
You were thinking about doing something special for MUCON, right? Maybe some shirts and
Some
stuff like
custom
that.
design shirts
Yeah.
and
And then possibly if patients wanted to get some consults afterwards, maybe the next day. But thinking about that too.
Oh, really? Just like...
Well, we're still figuring that out. But if they're already in New York City, and our office is literally Midtown as well as the conference,
yeah.
we're trying to figure out how to kind of maybe do some. Yeah,
Definitely,
yeah.
definitely.
So kind of if they're already out there, maybe just do a consult.
Could be a good opportunity.
Yeah.
At least take some scans and,
Yeah.
you
At
know,
least
leave you
get
guys
some
with some data.
Data collection. Yeah.
Yep. Yeah, I'm speaking at MUCON as well. I'm speaking at noontime, I think,
Yes, you are.
on Saturday.
Well, what you gonna be talking about,
I
man?
don't know. What do you guys think I should talk about?
I think you should actually talk about patient advocacy in the airway and facial development realm.
Right. That's my domain. Yeah.
I think you should talk about
I
that.
should keep my lane.
Correct.
Yeah.
I mean,
Yeah.
I think you've done a great job of introducing something to basically the world, right? Made it more mainstream, and I think that's you're very good at synthesizing information and presenting it back really, really, really well, right?
Yeah. Thank you.
Yeah,
Thank you.
I mean, I think you're definitely a huge pioneer in all this, and I think that yeah.
No, I appreciate that. Yeah, thank you. It's just in 20 minutes, you can only make so many points. I'm just trying to think.
So something you could be like what to look for in an orthodontist, what to look for in a surgeon, what to look for in a functional therapist. I don't know, something like that.
And
Right.
and what and how to navigate talk spaces, right? Like, hey, maybe some of the information on there is good, some of it is not good. There are places where you can actually have access to high level discussion amongst the people for these things, and I'm very impressed with a lot of that dialogue, but understand that it's happening in the context of people without formal training. And just to say that, I think is valuable.
And we will be launching a Patreon where we discuss a lot of educational stuff too, content.
You guys should launch a school instead of Patreon.
Okay.
Patreon's dead.
Oh, okay. Like a SKOOL
Yeah.
school. Yeah.
It's
I
going
know
to be
what
a
you're talking
paid
about.
membership?
Yep.
Oh, yeah, school all day.
Really?
That's what's his name?
Hormozy.
Hormozy right here.
Yeah.
Yeah.
All right, then we'll reach out to him.
Yeah.
Yeah, you guys, I'm thinking about doing something like that too. It's
yeah?
Not this year, maybe in the future.
Yeah.
But just a place where I could do like group calls.
Yeah.
You can schedule calls. You can put up video courses. You can put up PDFs. I think I'm not shilling for school. I don't know, but I think it's.
I mean, I've kind of, heard about school from, I follow Alex Hormozy anyways.
Yeah.
I've seen ads about it. Yeah, I think another good point is what, kind of touching on what Newaz was saying, was patients hyper obsessing over there in the talk spaces, Reddit and Discord, and just maybe advising them to kind of touch some grass.
Oh, you think
Some breathing.
take that route, huh? The mental
Maybe
health
just-
path.
Maybe just a little bit, because that's some advice that you had given me, and I was like, what the fuck, he's right. But yeah, just being so obsessed in
Breathe.
Yeah. And then doing like a 5-minute segment on game and how it's important to have game, not just a good jaw.
Exactly. Yeah, I mean, I think I think this whole idea. I mean, clearly, you go to parts of. I mean, you go to really any part of the world to see this phenomenon.
Tajikistan.
Let's go.
Dilek is over there.
I mean, you'll see very, very extremely attractive women with less attractive men. I mean, everywhere. I mean, it happens in my household. So, I mean, that's just a small example. But I'm just
That's
saying,
why we're getting you that for me, bro.
You're too humble. You're too humble.
nah. But I mean, that's the thing, though, is like, I think for a lot of these people out there who think that they don't necessarily have chances to mate and procreate with women, maybe you'll be more attractive to them if you're not constantly obsessing over your facial structure, right? Yeah. And now come to someone who understands your gripe about your own facial structure, right? Like us, to talk about that, but don't make your life about it.
Yeah.
There's
For sure.
Life is too short, and you have too many opportunities to excel at something, whatever it is you want to excel at, to be worrying about that kind of stuff.
Right.
I mean, look at me. I have 24 teeth in my mouth. I'm like, what do they call it? They would call me a jawlet. Right? I got these tiny ass jaws with the 25% of my teeth missing. I'm a jawlet.
Right.
Right?
Yeah.
And I'm not that tall. I'm overweight. I'm like, I'm not, you know what I mean? And,
Yeah.
but I've managed to do a thing or two in my life because I had a purpose and a vision,
Right.
and you know what I mean? And
Case in point.
yeah.
No, totally. No, you say it a little bit tongue in cheek, but it's actually,
Yeah.
it's an important point,
Yeah.
and there's countless examples.
Correct.
That it's not just about jaw structure,
Absolutely.
but it's hard to drive that point home.
Yeah. I mean, not only do I have really deficient jaw structure, let me tell you this. I don't have good jaw structure, and I have probably some of the worst sleep habits of anybody, and probably some of the, worst lifestyle sort of circumstances that permit really good, restful, regular sleep and sleep hygiene patterns. I'm functioning, I think, pretty good.
Why? What's the magic sauce there?
The power nap.
So we've talked about this before. A lot of this 8 hours straight, a lot of it, they say that it could have stemmed from the whole industrial revolution and working shift work, right? So when we were farmers and gatherers, you took a nap, you woke up at sunrise, you took a nap during midday when it's the hottest, and then you went back out, and then you went to sleep when the sun went down.
Right.
And then you could nap if you needed to. But with the Industrial Revolution, I mean, you kind of had to do your shift work.
Right. You have to pack it all in.
And then, I mean, in certain cultures, whether it's, Greece or Spain, you take the, siesta, right? And then some people are very good at doing polyphasic sleeping too, but they do blocks where there's some genius people like Dr. Newaz. I mean, I think Tesla used to do polyphasic sleeping. I think Deviation.
Yeah.
Right. And so, there's not a one size fits all to that either.
Right. What does polyphasic sleep mean to you? Does that mean splitting the night into 2 segments, or does that mean sleeping throughout the day and night and not even discriminating between day and night?
That could be it. Who knows? It's multi, more than one.
Yeah.
Versatile.
Sometimes you wonder how much
And also the thing is when, with sleep hygiene and things, people will start, they'll start obsessing about being tired the next day. So they'll get insomnia because of that. Like, oh man, I should be sleeping right now. Yeah. And it's a lot more, it could be mental.
It's totally mental.
Right? Because if they got out of bed and then left the room and then, I don't know, did something else, then they could probably fall asleep earlier and sooner than them obsessing about, oh, I'm going to be tired tomorrow.
And I do think that there's a degree of mental fortitude necessary to function in modern day society. I mean, and in other words, I think people need to chill the fuck out, and just kind of
breathe. I think
step by step.
And I think mindfulness and meditation is massive, right?
Yeah.
If you just chill, take a double. Was it Dr. Human says take a double breath?
Yeah,
right?
Double breath is good when you're working out too.
Yeah, it just relaxes you. I mean, everybody's so hyper and high tense and strung up. Life's gonna go on.
Yeah.
People allow their thoughts to control them. Mm-hmm. You have to be able to control your thoughts.
Yeah. And none of us are gonna make it out alive anyways. So
totally. No, not even a little bit. Yeah. All right, guys. Well, lots of wisdom there, and we'll end on that. And thank you for coming all the way up from New York,
Philly, Philadelphia,
New York, Maryland, to north of Boston, to my studio to record this podcast. I enjoyed it. And
me too.
Yeah, let's go have some dinner and play with the baby.
Yeah, buddy.
Haha. All right. Take care, guys.
Thank you.
Thank you.
Peace.